I'm going to go ahead and get us started. I do see that people are still joining, and so I'm going to just kick us off this morning, knowing that people are still joining the room. I just want to say thank you all so much for joining us this morning on Zoom. Historically, this has been an in-person event, which is a great time to network and see folks once a year. And we really appreciate your patience and your flexibility with having this event be in a virtual format again this year. So that being said, I do want to mention a couple of things. One is that you may have noticed this event will be recorded. It will be available on the Curry International TB Center's website following the event. That is also where you will be able to access your CME certificates. And so one thing I want to mention with the continuing medical education credits is that we are not able to award partial credit. So in order to receive CME credit, you need to be present for the full event today, and we will need you to complete our evaluation. One more thing is that we will be monitoring the chat. We have a Q&A box and we have a chat box. So if you have questions for our presenters throughout today's lectures, please feel free to drop them in the chat. We will be monitoring the chat, and then we do have time set aside at the end of each section in today's agenda to go over questions and talk through any concerns that come up. Speaking of the agenda, in the email that you received, there was a link sent to a folder with copies of today's slides and with our agenda. I'll make sure that we drop that in the chat in case anyone needs it, but you'll be able to follow along on the agenda and then download any slides from today's presentations. That being said, I think I'm ready to pass it off to our first speaker today. So you may have noticed, if you had a chance to look at the agenda, that we'll start off this morning by talking about STIs, and then we'll move into HIV, and then we'll wrap up with TB. So Rebecca Scranton is going to get us started this morning. Hi, Becca. You can go ahead and share your slides whenever you are ready. And I just want to say, if you've been to this presentation before, you may recognize Becca. She starts us off every year with what I think is a really informative presentation, just giving us a broad picture overview of what's happening in Arizona when it comes to STIs. So Becca is the Senior Chief in the Office of Disease Integration and Services at the Arizona Department of Health Services. And with that, I'm going to pass it off to her.
Thanks, Britt. Just want to confirm you can see my slides and not my notes. Awesome. Hey, everybody. It's so nice to be with you all here today talking about STIs, one of the topics that is near and dear to my heart. First off, disclaimer, basically the views expressed in this presentation do not necessarily reflect those of the federal government. And I am a state employee, so I have nothing further to disclose. So by the end of this presentation, you will be able to interpret statewide STI surveillance data and explain trends in recent years to identify strategies for overcoming barriers to testing and treating patients. You will also be able to discuss progress toward implementing the new treatment guidelines to better manage patient care. This curve represents the combined case reports for chlamydia, gonorrhea, syphilis, which are the three main pathogens that we surveil. Just going to minimize my screen here. Okay. In the past 2 decades, STIs have continued to rise in Arizona, though we did notice a slight dip in case reports in 2020. But when we take a closer look at the change between 2019 and 2020 by morbidity, we see that the dip was really caused by a slight drop in chlamydia cases, whereas gonorrhea and syphilis continued to rise. And although 2021 numbers are also still preliminary, I can tell you that 3 pathogens will increase from their 2020 count. Chlamydia will likely not exceed the 2019 case count, but it will be at least 38,000 cases for 2021. So before we take a look at some congenital syphilis data, I wanted to pause and explore some of the context for why we saw a drop in chlamydia cases in 2020. Early in the 2020 pandemic, social distancing as well as bar and restaurant closures may have temporarily disrupted patterns for how people meet their sex partners. But we also saw disruptions in STI prevention services. And we heard anecdotally that demand for testing may have decreased due to people deprioritizing routine healthcare or not having access to the economic means to receive screening services. This is particularly problematic for STIs, especially chlamydia, since the infections we surveil are often asymptomatic and people may not know they're infected until they get tested. We also heard of STI clinics having to reduce their hours due to the involvement in the COVID-19 response effort. We see the impact of reduced testing in this graph, which compares STI testing rates in 2019 to 2020. 2020 are the blue bars for the testing that we fund. So this is mostly county health clinics and family planning centers. This also forces us to think creatively about ways to expand access to testing in other areas during the pandemic. Unfortunately, the home testing options for bacterial STIs range from limited to non-existent. So our attempts to offer alternative testing opportunities have been challenging. As we started scaling up alternative STI testing options through some subcontracts with local organizations, around August of 2020, there was a shortage of testing supplies for chlamydia and gonorrhea. And the STI test kit shortages continue to this day. Most recently, there has been a shortage of blood collection tubes, which impacts syphilis and HIV screening. In addition to all of the testing issues and individual factors that led to surveillance decreases in reporting, our contact elicitation practices were also disrupted. So for syphilis, we actually interviewed cases and tried to identify partners and link them to care and treatment. But in early 2020, local STI staff who do that activity were being deployed to COVID-19, especially in rural Arizona. So that impacted our ability to find contacts and connect them to testing and treatment. For STI control, contact linkage to care is an incredibly important tool for mitigation of community transmission. Again, because these infections tend to be asymptomatic or the symptoms go easily unnoticed. And there's also a lot of stigma around STIs. So when someone tests positive, they face a lot of challenges in doing partner notification. And that's what the health department steps in and helps with. And all of the challenges that we face in testing and linking people to care mean that not only are STI cases increasing in youth and adults, but the cases are increasing in newborns. We are most concerned about syphilis in newborns because it can be deadly. Where once we averaged 14 cases a year, we are now averaging over 100 cases a year. By November 2021, we had already surpassed our 2020 congenital syphilis case count with 135 cases, 11 of whom were stillborn. And I think the most recent count is now over 160, and we're still wrapping up cases for data closeout. So this number will continue to increase. The increases that we're seeing in syphilis in babies are a reflection of what we see in persons of childbearing capacity, which is why it is critical to be thinking about the potential for congenital syphilis when working with growing families and persons who are pregnant. We are seeing an increasing number of pregnant persons in the past 2 years were not connected to prenatal care, which is why we're observing missed opportunities for prevention. Linkage to testing and treatment for pregnant persons is critical for preventing congenital syphilis. 2021 was a big year for STIs, and there are two major events that I want to highlight to set the stage for our clinical presentation. First and foremost, STI programs across the nation received an historic funding increase. For over a decade, STI programs have been flat funded in spite of the nationwide increases in morbidity. And we've already discussed how thin our resources were further stretched in the past 2 years when our local investigators were deployed to the COVID-19 response. But all of that changed last summer when our federal funders released a brand new grant to expand case investigation capacity. In Arizona and across the nation, we are using these funds for multiple morbidities, including STIs and HIV. This new workforce will help us to respond to the rise in STIs. If you'd like to learn more about how we're using the new funding in Arizona, I'll be presenting with my colleagues at the virtual HIV symposium during the first week of May, and I believe registration for that event just opened up, and you'll see a slide for that in, I think, our slide deck for the break. The second thing that I want to highlight is that we have a new STI treatment guidelines. So prior to this release, we were using guidelines from 2015. And at the end of December 2020, we received some updated guidance for gonorrhea treatment, and the full report was released September 2021. So today you're going to hear about the treatment updates and how to operationalize them in your clinics. But before I pass this on to Dr. Adler, I have a little bit more data to share. So the goal of this visualization is to see how clinical prescribing in Arizona has changed after the release of the guidelines. So the top bar of this graph shows treatment data from 2020, which we can consider pre-2021 guidelines data. And the bottom bar shows data from August to January of 2021. So we can use this as, August 2021 to January 2022. Needed more coffee this morning. So we'll consider this post-guidelines data. Although penicillin therapy was recommended for syphilis treatment in both the 2015 and 2021 guidelines, at least from my perspective, it seemed like the use of doxy as an alternative therapy was very much de-emphasized. There's a lot of additional guidance around how to navigate allergies to penicillin and how to validate when someone reports a penicillin allergy, how to desensitize them in the event of a true allergy, especially if they are pregnant, because penicillin is the only option if you are pregnant for treating syphilis. And what we see is that after the release of the guidelines, we see an increased uptake in the use of penicillin, which is a good thing. The next thing that we're seeing is a strong uptake of the new gonorrhea treatment guidelines, also a very good thing. So before the release of the guidelines, the primary therapy that we were seeing prescribed was the dual treatment with ceftriaxone and azithromycin. And again, they were following the 2015 guidelines, so this is what we would expect. After the release of the 2021 guidelines, we're now seeing about 88% of people being prescribed the new therapy, which is twice as much ceftriaxone and no azithro. So we're moving away from dual therapy for gonorrhea. So again, this indicates that providers are doing a really good job in our state of adopting to the new guidelines in Arizona, at least so we think. So the bad news is we don't always get treatment when we get our communicable disease reports. About half of our cases are missing treatment information. And this really does make it very difficult to know how widespread the uptake of the new treatment guidelines are. Makes it hard to know who among those 49% haven't been treated. So it's very hard for us to actually prioritize these cases for connection to care when we are drowning in tens of thousands of case reports every year. So this is a little bit of a challenge getting good treatment data on our gonorrhea and chlamydia cases. So for anyone who doesn't know where to find our communicable disease reporting form, it is available at azdhs.gov/CDR. Please be sure to complete this form and submit it to your local health department whenever you have someone testing positive for a reportable condition. The fax numbers for the local health departments are listed at the bottom of this form, and that red box on the side highlights where treatment information can be entered. These CDR reports really are important because often we get additional case information like treatment and lab that the lab may not have access to, and this really does help us prioritize our STI control efforts. We do use the information from these reports to determine which cases should be prioritized for linkage to care, and if information is missing, it impacts our ability to provide timely and effective interventions. So thank you all so much for everything you do to keep our state happy and healthy, especially during this past couple of years. If you want to chat more about STIs or our work in Arizona, or if you want to learn more about some of our upcoming events, feel free to reach out anytime. Okay, now I'm going to try and go back to Zoom. Am I no longer sharing my screen?
We still see your slides.
Oh, oh gosh, let me see if I can fix that. Oh. Ha, wonderful. All right, still working on the Zoom skills. All right, now I'm going to pass it over to Dr. Adler. Dr. Adler is clinical faculty at the California Prevention Training Center, which is our regional prevention training center. She is also an assistant clinical professor at the University of California, San Francisco in the Department of Family and Community Medicine. Dr. Adler has worked in the STD field for more than 20 years, including 10 years of work at the California Department of Public Health STD Control Branch. She is board certified in preventive medicine, public health, and has clinical experience working in community health and public health clinics in the San Francisco Bay Area, as well as the San Francisco STD Clinic. I'm so happy to welcome you today, Dr. Adler.
Thank you so much, Becca. I'm just having a little bit of technical difficulties as well. But let me go back one slide. So happy to be here with all of you in Arizona. I'm here virtually with you, based in California, but I often have come to Arizona to give this presentation. I'm really honored to be here and be a part of this training. I'm going to be giving an update on the 2021 CDC STI treatment guidelines. Rebecca just mentioned them, and I'm going to try and synthesize and give you kind of the top 10 key updates. And I have the same disclaimer that was already presented. None of the content is federal government content. And I personally do not have any disclosures in terms of any financial relationships. So we'll go on to my next slide, which is my learning objectives. I just need to do one other tweak so I can see all of my slide content. Okay, so by the end of today's presentation, you should all be able to discuss the current STI screening recommendations that are enclosed in the 2021 treatment guidelines. And these are important to know to ensure that infections are diagnosed and treated. And you should all be able to describe at least 3 updated treatment regimens for STI management and 3 follow-up recommendations that are new in the 2021 treatment guidelines, and use this information to inform and optimize decision-making with patients. All right. So in 2021, CDC came out with the new guidelines, and they also, if you're paying close attention, did a slight name change. And so prior guidelines in 2015 were referred to as sexually transmitted disease guidelines, and now we're referring to as sexually transmitted infection guidelines. And use of the STI term is just a broader term because it refers specifically to the pathogen, and it also incorporates asymptomatic disease. And these are kind of interchangeable terms, but this has been a shift that's been happening in Europe. They've been using the term STI for many more years. You can use the terms interchangeably, but now CDC has decided to take on this broader term. So it refers not only to, the earlier stages of infection and includes asymptomatic infection. And that is what came out in 2021. I'm going to first share a couple slides that go over a little bit of the background on how these guidelines are developed, and then we'll launch into a lot of detail around the updates. So these truly are evidence-based guidelines. CDC uses 4 principal outcomes of STI therapy, and these 4 outcomes are microbiologic eradication of the pathogen, alleviation of signs and symptoms, prevention of sequelae, and prevention of transmission. And when they're looking at the different regimens for treatment. And so when you see a recommended regimen versus an alternative regimen, that recommended regimen meets some of these 4 evidence-based outcomes, and that's why it has been deemed a recommended regimen. They also take into account some of the advantages of different regimens, like is it a single dose? What are the cost effectiveness of it? Is it can be given as daily observed therapy? Or what are some of the disadvantages in terms of side effects? And so these are all taken into account when the treatment regimens are discussed. And then when you look at the treatment guidelines, you will see a whole list of regimens, and they're alphabetized usually, unless there is a specific priority of choice. And then a different medication might be listed out of alphabetical order. As Britt mentioned, or as Becca mentioned, excuse me, the guidelines came out in July of 2021, and here's a link to the full document. And then there is an app. I think the CDC is planning on releasing the app in April at some point, because that is next week is STI Awareness Week. And so they're hoping that the app is going to be released. It's going to be a much more user-friendly app than the 2015 one. But right now there's just an interim app up on the CDC site, and the link is at the bottom of my slide. This next slide is just a graphic kind of to detail all of the work that goes into creating these guidelines. And so the CDC does convene a whole host of subject matter experts. They do a systematic review of the current evidence. They have tables of evidence, they have background papers, and then they meet. And for this guideline meeting, it took place in June of 2019. It was a 3-day meeting with CDC staff as well as national experts. And at that meeting, they attempt to answer some of the key questions in the STI field, rate the quality of evidence, and compare it to the U.S. Preventive Services Task Force. They also attempt to set a future research agenda if there are questions that have not been answered based on current data. And then they draft the guidelines. And then you can see there's a little bit of a delay between June of 2019, 2021 guidelines, and that's, we all know, we had COVID, so things got delayed, and we were so happy when the guidelines finally came out in 2021. I think we were expecting they would come out in 2020, but other things happened in 2020 that really we all are aware of if you're working in public health. So this slide and the next slide, I'm going to go through, quickly the top 10 updates, and then the rest of this presentation will go into detail for all of these things. I just wanted to give you a 2-slide overview of what the top 10 updates are. So in the prevention and screening section of the guidelines, there's a whole new section on transgender persons and gender diverse persons that is new. And in addition, there's new content around screening adolescent females for gonorrhea at extragenital sites. In addition, in prevention and screening, there's new content around hepatitis C screening. There's kind of a theme around increased recommendations around hepatitis C screening. For chlamydia and gonorrhea, there's new treatment guidance for gonorrhea that Becca already mentioned, and we'll go in detail and discuss what that is. And there's also new treatment guidelines for chlamydia. And then there's a new broad recommendation to test all patients with a tested cure for pharyngeal gonorrhea. Mycoplasma genitalium, if you haven't heard of it yet, it's no longer an emerging pathogen. We really are seeing a lot more Mycoplasma genitalium, and there's a new section on this, and as well as sequential treatment, and we'll talk about what sequential treatment is when we get to that section. In terms of the STI syndromes, in terms of PID treatment, we have a new recommendation around the use of metronidazole or the addition of metronidazole, and I will detail that. In the genital ulcer disease section, there are no new treatments, and so it's the same treatments for syphilis, neurosyphilis, and herpes, but there's some changes as it relates to diagnostics recommendations and follow-up guidance, specifically for syphilis, and guidance around who needs to have a lumbar puncture. And then in the vaginitis section, new treatment recommendations for TRIC, and some new diagnostics for BV and alternative treatments. So that is my brief update. And then now we're going to go into detail to cover all of that content. So first, we're going to move into the screening section. And throughout my slide set, the content that is highlighted in yellow means that it is new in the 2021 treatment guidelines. And so you can see there's a lot of content on this slide. The vast majority of the content in terms of screening for adolescents is not new, but I will go over it. So there has always been a recommendation for many, many years to screen young females for chlamydia and gonorrhea, so that remains. But what is new is there's now a consider recommendation, and that means that there wasn't necessarily consensus among everybody. There isn't the strongest data, but there is some data that we know that young females are getting infections at extragenital sites, and so you might consider screening them for gonorrhea and chlamydia at the rectal site and for gonorrhea at the pharyngeal site. In terms of males who have female-only partners, there has never been a recommendation to screen this young population routinely for chlamydia and gonorrhea, but it is a shared decision-making with them, and you might consider it in settings that have known high incidence, and these settings include correctional settings, STD clinics, and adolescent clinics. No changes around HIV screening for young adolescents. In terms of TRIC for young adolescents, you might consider the local prevalence when deciding to screen, and there is a recommendation to screen for TRIC among all persons entering correctional facilities. For syphilis, young men who have male partners and pregnant females should be routinely screened, and we'll go into detail what the screening recommendations are in those populations on the next slides. All right, so in terms of transgender persons and gender diverse persons, CDC has a new section on this. And in this section, the main take-home message is that you want to screen based on the person's current anatomy. Don't make any assumptions. And you also want to assess what the gender of their sex partners are. And in terms of current anatomy, we have some data from the National Transgender Survey that demonstrates that most transgender persons actually haven't undergone surgical procedures. A small proportion have. More trans women have than trans men, and that's based on limited data, but that is the National Transgender Survey. So you really want to do an assessment of what their anatomy is to determine what screening they should have. We'd want to offer HIV screening to all transgender persons. And just to be aware that transgender persons, if they're living with HIV and they have sex with cisgender men, they're at similar risk for STIs as other cis MSM. And so we'd want to screen them similar to the recommendations around screening MSM. Some transgender women, if they have had a vaginoplasty, so they've had a creation of a vagina, you would want to screen at all sites. And at this point, there isn't data around what type of swab to use. And there is more detail on this. And if you are a provider who takes care of transgender women, you should be up on the detail around what swab to use. But we don't have data yet whether it should be a urine specimen to screen or a vaginal swab. But it may be, you may need to do an assessment of what tissue was used to construct the neovagina. Transgender men, some of them may have had a metoidioplasty, and that is a lengthening of the clitoris. But they also may still have a vagina. And if they have a vagina, then you're going to need to screen using a cervical or vaginal swab. And so that's why an assessment of what the current anatomy is important. All right, now we're going to move on to talk about screening for cis women. I actually cannot see the top of my slide. Let's see. I think this is just my cis women slide. This is a challenge with the Zoom. All right. So screening for cis women, there's always been a recommendation to screen women under the age of 25 to screen routinely for chlamydia and gonorrhea. But what's new is highlighted in yellow here. And you're going to see a theme around hepatitis C screening, which is why it was one of the top 10 updates, is that you want to screen for hep C at least once if the woman is over the age of 18, unless you know that in your clinic setting that there's a very, very low prevalence of hep C. And the reason why there's all this new hep C screening is that we have better treatment for hep C. So we want to identify it because we now can treat it. For women who are 25 years of old or age or older, you would screen for gonorrhea or chlamydia based on risk and some of the risk factors that are in the CDC treatment guidelines. And I want to say these are national kind of known risks. Your particular state may have different risks, but some risk factors to consider would be new partner, more than one partner, sex partner who has concurrent partners, a sex partner who's known to have an STI, transactional sex. These are things to consider in older women over the age of 25. And then HIV screening hasn't changed at least once in both of these populations of women. Now screening for pregnant women. Again, what's highlighted in yellow here is that you want to screen for hep C in all pregnant women, unless it's known that you have a low prevalence of hep C in your community. And you want to screen at every pregnancy in these women. And then no changes around screening for HIV or syphilis. And these are, again, are the national STI treatment guideline screening recommendations. You may have different state recommendations around screening, particularly for syphilis, if there's a lot of congenital syphilis in your state. But for HIV, you want to screen at the first prenatal visit. And then if there's risk, retest again during the third trimester. And some of the risk factors for HIV that are mentioned in the treatment guidelines are similar to the ones for GC, newer multiple sex partner, live in an area with high HIV prevalence, unknown partner with HIV, history of drug use, or symptoms of acute HIV. And then for syphilis, this hasn't changed. You want to screen at the first prenatal visit. Then in terms of national guidance, the CDC says you want to, if there's risk, you would retest during the third trimester, ideally at 28 weeks, and then plus again at delivery. For pregnant women or pregnant persons who are under the age of 25 or are over 25 and have some risk factors, you would screen for chlamydia and gonorrhea at the first prenatal visit, plus retest again during the third trimester to try and detect infections that may have occurred during pregnancy. All right, moving on now to screening among men who have sex with men. Again, highlighted in yellow, we have new recommendations around screening for hepatitis C. So this is the theme. For hepatitis C, you want to screen at least once if the person is over the age of 18, unless, again, prevalence is known to be very low. And then also a new recommendation around anal cancer screening. So an annual digital anal rectal exam should be done. And this may be useful to try and detect early lesions of anal cancer. And at this point, the CDC is not recommending anal PAPs. I just want to highlight that there has been a study that we've kind of been waiting for. It's called the Anchor study that was looking at persons living with HIV with changes on anal cytology and anal PAP to see whether treatment actually reduced anal cancer. And that study came out since the 2021 treatment guidelines have been released, but I think that there may be changes in the field around this in terms of anal PAP recommendations, but not yet in the 2021 treatment guidelines. So no other changes in terms of recommendations around screening men who have sex with men, but I'll just review what the recommendations are. So you want to screen for HIV in this population. You want to screen for syphilis. You want to screen for urethral gonorrhea and chlamydia, rectal gonorrhea and chlamydia if the person is engaging in receptive anal sex, pharyngeal gonorrhea if the person's engaging in oral sex. And the screening recommendations for all of these STIs are annually, but possibly more frequently if the person has multiple or anonymous partners, drug use, or partners with risk. No changes around screening for hepatitis B, and you might consider herpes 2 serology in these patients as well. And this slide just goes over the fact that it's really important to take a sexual history. The way that we know what types of behaviors our patients are engaging in is by assessing their sexual history. And what's highlighted in yellow is updated in the 2021 treatment guidelines. And that is kind of newer language about how we take an assessment of sexual partners. And so what the CDC is recommending is asking, using more gender neutral language. So to ask, what are the genders of your partners? In the past, we have used language such as, are your partners male, female, or both? But this is more gender neutral language just to ask about the genders of your partners. And the other content that has changed in terms of sexual history is to assess about pregnancy intentions versus pregnancy prevention. This is just recognizing that there may be some patients that are actually intending to have this pregnancy or have intentions for pregnancy in the future. And so the language is a bit broader in that section. All right, we're going to get to our first poll here to try and engage you guys in the room. And we're going to move on to the section where we're talking about treatment. So I'm going to poll all of you, and the poll is going to come up. How would you treat an asymptomatic female who has a test that comes back positive for both gonorrhea and chlamydia? This is her vaginal swab. Are you going to treat her with ceftriaxone 250 plus azithromycin 1 gram? Are you going to treat her with ceftriaxone 250 plus doxycycline 100 milligrams twice a day for 7 days? Are you going to treat her with ceftriaxone 500 milligrams plus doxycycline 100 milligrams twice a day for 7 days, or are none of the above what you're going to use? And I can't see if people are responding, but I hope that you are. And in a few moments, I believe we're going to get the poll in so we can see how you guys have responded if you're current and what the treatment guidelines are for gonorrhea and chlamydia. Are we ready to show the results? All right, great. So it looks like 56% of you got the correct answer. So that's great. A little bit more than half of you. And then the top two, you're going to learn why these are the new recommendations. And so the first choice was actually what was recommended previously in the 2015 guidelines. That's the 17%. But the correct choice is C. And so I'm going to close this out, advance my slide set. Let's see. We're not advancing. Here we go. So this is highlighted. This is what the correct regimens are, and we'll go into detail now and talk about the changes in the gonorrhea section as well as the changes in the chlamydia section. All right, we're going to start with chlamydia. So for many, many years, there have been numerous studies that have looked at the efficacy of doxycycline versus azithromycin for urogenital chlamydia. And this is a slide that compiles them all. This is thanks to Dr. Will Geisler, who's a national expert in the field of STIs and infectious disease doc. And you can see doxycycline is highlighted in the kind of gray colored, azithromycin is in blue. There's similar efficacy, but the pattern has been, even for urogenital chlamydia, that doxycycline was slightly more effective, but there wasn't, I don't think, statistical significantly different differences in these treatment regimens. And so that's why for many, many years, azithromycin was the primary regimen to treat chlamydia. Oops. I skipped a slide. We'll go back. All right, so now on this slide, we're looking at doxycycline versus azithromycin for rectal chlamydia. So doxycycline is in the darker blue, and then azithromycin is kind of in the navy blue color. And there has been some evidence over numerous years, but these are all observational studies that were letting us know that azithromycin might not be so great for treating rectal chlamydia. And there have been many STI experts who have shifted to using doxycycline for rectal chlamydia, but we didn't have a randomized controlled trial on this. And that changed in 2021. And so this slide is reviewing a study that was by Julie Dombrowski, came out in CID, that demonstrated when you compare doxycycline to azithromycin for rectal chlamydia, and your outcome is microbiologic cure at 4 weeks, doxycycline is much more effective. And so doxycycline is in the blue, 100% efficacy compared to azithromycin, only 74% efficacy. And this was statistically significantly different. And so therefore the CDC now in 2021 is recommending for all chlamydia at all sites, urogenital, rectal, and pharyngeal, you want to use doxycycline. And this is only for non-pregnant persons because we can't use doxycycline in pregnancy. And so this is new in 2021. So we want to use doxycycline 100 milligrams twice a day for 7 days. That is the recommended regimen, and this is based on efficacy. Azithromycin remains as an alternative, as does levofloxacin. And we know that there may be some patients who you really are concerned about their ability to take a medicine twice a day for 7 days. That can be very challenging. And in those patients, you may use the alternative azithromycin, but you want to think that, is this someone who might have a rectal infection, and you might want to screen them at that rectal site to make sure that you're giving them a treatment that's going to work if they're at risk for having a rectal infection. And so in terms of treatment in pregnancy, we can't use doxycycline, and so azithromycin is what is used in pregnancy with amoxicillin as the alternative. And in pregnancy, there always has been a routine test of cure recommendation, and so we're going to know whether this regimen worked for that pregnant woman or that pregnant person. All right, so there's been a lot of changes in chlamydia. Hold on to your hat, kid. There's more in gonorrhea. We're going to move on to gonorrhea right now. All right, so for gonorrhea, just a bit of background around gonorrhea. If you've been in the STI field, you know that there's been concerns about antimicrobial resistance for gonorrhea for many, many years. And this is a slide that was presented at the National STD Prevention Conference back in 2020. And what it reveals is that more than half of the isolates are resistant for gonorrhea, are resistant to at least one antibiotic. And so the pie chart on the left is data from the gonococcal isolate surveillance project from 2009. And in 2009, the large part of the pie is this green color. 76% of the isolates were susceptible to all antibiotics. The situation has changed in 2019. In 2019, only 45% are susceptible. So more than half are resistant or have decreased susceptibility to at least one antibiotic. And so that is kind of the arena that we're working with in terms of treatment for gonorrhea, that there are concerns about antimicrobial resistance that are continuing to evolve. This is more data from the gonococcal isolate surveillance project, looking at the years 2010 to 2019. And we're looking at isolates that have decreased susceptibility to various antibiotics. And the pink bars are azithromycin. So we can see there has been a dramatically increase in azithromycin resistance. It went from in 2010 to be less than 1% of the isolates to more than 5% in 2019. The good news in terms of the medicines that we're using to treat chlamydia now, ceftriaxone in yellow and cefixime in green, those have remained low or actually decreased. And so changes in azithromycin, decreased susceptibility on these isolates also has led to the CDC to saying that we're going to be using monotherapy. And so on this slide, we're reviewing what the new gonorrhea treatment guidelines are. This is for uncomplicated infection. The mainstay of treatment is going to be ceftriaxone 500 milligrams in a one-time dose. And that is for persons who weigh less than 150 kilograms. If you have a patient who weighs more than 150 kilograms, you would give them a higher dose, 1 gram. You no longer routinely need to give people azithromycin. If this is somebody you're treating syndromically, like say you're treating them syndromically for urethritis, or you want to cover them for both gonorrhea and chlamydia, and chlamydia has not yet been excluded, you're going to give them treatment for chlamydia with doxycycline, 100 milligrams twice a day. But if you're screening somebody for both gonorrhea and chlamydia, and their tests for chlamydia are negative, and you're just treating gonorrhea, you just need to use the ceftriaxone at the 500 milligram dose. The other thing that is new, and this is highlighted in yellow at the bottom here, is there now is a routine test of cure for every patient you're treating for pharyngeal gonorrhea. In 2015, it used to say only test those who are getting an alternative regimen. We're now saying routinely do this in everyone who's treated for pharyngeal gonorrhea, and that's because it's just the pharyngeal site is a site that's harder for the antibiotics to get in, and we know it can take more time for gonorrhea to be eradicated at that site. CDC says test of cure at 7 to 14 days, and I've highlighted the 14 in red, and that's because in California, we're saying out to 14 days. I don't know if Arizona has specific guidance around this, but we know that it can take a long time for that pharyngeal gonorrhea to be cured, even with the ceftriaxone 500 milligram dose. And so we wait out into 14 days to get that test of cure. In terms of alternatives, now these are alternative regimens for gonorrhea treatment only for cervical, urethral, and rectal. There are no reliable alternatives available for pharyngeal gonorrhea. You have to use injectable cephalosporins. And that's because we know that cefixime, which is an oral regimen, does not penetrate the mucosa of the pharynx. And so it's not going to get in to treat pharyngeal gonorrhea. There are some alternatives if you have a patient that has severe cephalosporin allergy, and it's gentamicin 240 milligrams IM plus 2 grams of azithromycin. The other updates as it relates to gonorrhea and chlamydia relate to expedited partner therapy. This is a strategy of how to get medication out to partners who are not going to come in for testing and exam. And at this point in 2021, EPT is either allowable or potentially allowable in all states, which is wonderful. It wasn't, 10 years ago, 15 years ago. So no states prohibit it at this time. And in the CDC guidelines, previously, this strategy was really only recommended for persons who were in heterosexual relationships, male-female partnerships. And now the CDC is saying you can use EPT for men who have sex with men. So they've expanded that recommendation. All right, I'm going to see who's awake in the room with another poll here. So we have a patient who has persistent urethritis. He was seen 2 weeks ago. He was seen 2 weeks ago and treated for urethritis. He was given treatment to cover for gonorrhea and chlamydia with ceftriaxone 500 milligrams plus doxycycline, but his discharge never resolved. He's had no new sexual exposures, and his testing for gonorrhea and chlamydia were negative from the last visit. So what do you think is the most likely cause of his persistent urethritis? Do you think it would be gonorrhea, chlamydia, trichomonas, or mycoplasma genitalium? And we'll give you a few moments to see what you guys respond. And then I'll leave it up to my tech assistants to share the poll results when we have enough people that have been responding. And we'll see what you guys think is the most likely cause of his persistent symptoms. Great. Okay. 44% of you said mycoplasma genitalium, 33% said trick, a few said gonorrhea, and a few said chlamydia as well. So let's see what my response is on this next slide. All right. So the 44% that got mycoplasma genitalium, yes, that's probably is the most likely cause of his persistent urethritis, followed by trichomonas. Probably unlikely that it's chlamydia and gonorrhea because he was tested, and our tests are pretty good. But some patients could have persistent symptoms because of, antibiotic treatment failure for gonorrhea. I don't think this is the case because his tests were negative for both gonorrhea and chlamydia. All right, so mycoplasma genitalium. Let's move and launch into that section. So we now have emerging information. I wouldn't even say emerging information. Over many, many years, it's now been revealed to us that this is truly a pathogen, an STI. More than 1 in 4 men who have urethritis, it actually ends up being mycoplasma genitalium. So about 25% of the time, it is MGent. And the CDC recommends that you want to test for MGent in patients who have persistent urethritis that fails the initial treatment. You also might consider testing for MGent in patients who are presenting with persistent PID manifestations or persistent cervicitis symptoms. And the good news is we do have a test for this. When I would give these presentations back before 2019, we didn't have any diagnostic tests. We now have a diagnostic test. It's a NAT test, similar to the test that we use for gonorrhea and chlamydia and trick. this test really only should be used in patients who have persistent manifestations. We don't want to screen the population for MGen. It is not recommended, and that's because we don't know yet that screening changes outcomes. There has been no studies to look at that, or screening reduces serious sequelae in both men and women. So there's no screening recommendation for MGen. There is a recommendation to screen in patients who have persistent manifestations. The challenge with MGen, and you'll see there's a theme here around antimicrobial resistance, is that we have antimicrobial resistance. And so this is a slide courtesy, courtesy of Laura Bachman at CDC. This is a study that she was involved with folks at CDC, looking at isolates that came from men who had urethritis from a variety of STI clinics throughout the country. And so these are all the sites of the STI clinics, and highlighted in dark blue. These are men who presented with MGen who had urethritis, and they looked at those isolates. Is that more than 50%, sometimes up to 60%, had this particular mutation. That's the 23S mutation. This 23S mutation highlighted in this dark blue is a mutation that is associated with azithromycin failure. So it's a macrolide, which is a azithromycin mediating mutation, and it correlates with treatment failure. Some of these isolates also had a mutation called PAR-C, and that's highlighted in green, and the yellow ones have both of the mutations, and that mediates fluoroquinolone resistance. And so we have challenges in terms of treating MGen because of resistance, particularly because of resistance to azithromycin. So how are we going to be treating our patients who have been identified with having MGen? In the 2021 treatment guidelines, the CDC outlined a new strategy, and that strategy is what we call sequential treatment. And so you're going to start with doxycycline, and that doxycycline actually reduces the bacterial load of MGen. And then you're going to give another medicine. And what's recommended is that most places in the United States, because it's not FDA approved, do not have resistance testing. And so you're going to be following this first strategy, which is treat with doxycycline for 100 milligrams twice a day for 7 days. And then after completion of that, then the person gets moxifloxacin, 400 milligrams daily for 7 days. If you happen to be at a clinic site that has resistance testing, which would really only be a research setting because it's not FDA approved, then you could use a different strategy. And that would be where you start with doxycycline. And in this setting, you would know that the person doesn't have that mutation that would give them decreased susceptibility to azithromycin, so you could treat with azithromycin. But I'd say the mainstay in most clinics in the United States is going to be with doxycycline, and then followed by moxifloxacin for 7 days. And I realize that I'm going through this quickly, but I think there's going to be plenty of time for questions at the end. And I'd say for the arena of MGen, we are getting a lot of questions, and we have a consult line nationwide that I'm going to share with you that as a resource at the end of the presentation as well. So we're going to move on and talk about some of the updates in the syndrome section, specifically focusing on the updates around PID. And I'll just mention how urethritis and cervicitis typically is managed. And so for PID, there's always been a question as to whether metronidazole to treat kind of the anaerobic infection of PID should be routinely used. And in the prior guidelines, they were written as the regimen with or without metronidazole. And we were kind of waiting for a randomized controlled trial, and this did take place in 2021. And the results were reported in CID. And so a randomized controlled trial took place with over 233 cis women. And these women were randomized to receive either ceftriaxone plus doxycycline plus metronidazole, or they were given ceftriaxone plus doxycycline with a placebo. The primary outcome of this trial was clinical improvement at 3 days. And in addition, these women were assessed for anaerobic organisms in the endometrium at 30 days, changes in their fever, and cervical motion tenderness reduction. So interestingly, clinical improvement was similar between the two arms at 3 days out. However, metronidazole, when that was added to the regimen, it statistically significantly reduced the number of anaeroes in the endometrium, the detection of genitalium, as well as some of the physical signs of cervical motion tenderness and pelvic tenderness. And so the take-home message of this study was that metronidazole should be routinely added for the treatment of PID. And that is what the CDC has incorporated in the 2021 treatment guide. And so what I'm showing you here is oral outpatient regimens for PID. And so if you're giving treatment with PID, you want to treat with ceftriaxone plus doxycycline, and it's no longer with or without, it's with, and you want to give metronidazole. So that is the update for PID. In terms of treatment for urethritis or cervicitis, ideally you want to treat based on knowing what the pathogen is, but we know that if someone's coming in with urethral manifestations, unless you have a rapid test for gonorrhea and chlamydia, and that's just another update in 2021 is there actually was an FDA approved test that was recently approved as a point of care test. And so this may change STI management in the future, but right now most people are doing send out tests for gonorrhea and chlamydia. And so you're going to want to treat for both gonorrhea and chlamydia, like our case patient that I was sharing earlier. In patients who have cervicitis, what the CDC recommends is that you want to treat with doxycycline. And if the person has increased risk for gonorrhea, you might add treatment that would cover gonorrhea. And so if the person is less than the age of 25, has a new sex partner with a concurrent partner, sex partner with an STI, then you would add treatment with gonorrhea by adding ceftriaxone. And then also in someone who presents with cervicitis, you want to assess for BV and trick and treat for these if they are detected. If someone is low risk, it does not meet any of these criteria, you might just test her and defer treatment until her results are available. All right, we're going to forge ahead and talk about what the changes are in the GUD section, syphilis and herpes. And as I mentioned, in terms of syphilis, there are no treatment changes. Benzathine penicillin remains the mainstay of treatment for syphilis. There is actually an ongoing randomized control trial to compare 1 shot versus 3 shots of benzathine penicillin for early syphilis. And that's because all of the data that we have around syphilis is based on historical use. We have not done a randomized controlled trial. And so it'll be interesting to see what this trial reveals. But at this point, we're still treating early syphilis with 1 dose of benzathine penicillin. In the guidelines, there are some changes in terms of the content around discussions of what the typical presentation of syphilis is. And we all know that syphilis usually presents with a solitary ulcer that is painless. But there is information that syphilis can present with atypical manifestations. And so you can have someone who has multiple lesions, and you can have someone who has painful lesions as well. Other updates in the syphilis section relate to follow-up. And so when you diagnose somebody with syphilis, you want to assess them by serology at specified time periods. And there now is consistent data that shows it may take some time for the serologies to drop 4-fold. So for primary and secondary syphilis, you would expect it might take out to 12 months for that serology to drop 4-fold. And that's okay. The prior guidelines said 6 to 12 months. They've taken out the 6 and recognized that it may take longer for serology to drop 4-fold. And it may take out to 24 months in persons living with HIV. For latent syphilis, we would expect that serology to take even longer time. It might take 24 months for that serology to drop 4-fold, especially if the titer, it's really only going to drop if titers are initially high. The other change in the guidelines as it relates to neurosyphilis is we have now data from at least 2 studies that demonstrates that if we follow their serology, we follow their RPR, if that drops appropriately, that the RPR drop actually predicts the normalization in the CSF. And so there were studies that were done in persons living with HIV who are on antiretroviral therapy and persons who are HIV uninfected. And so now the guidance says if we're treating somebody for neurosyphilis, they initially had an abnormal CSF. As long as their RPR drops appropriately, you do not need to get a repeat CSF at 6 months. And so that's kind of the good news in terms of reducing the amount of lumbar punctures that we have to do on our patients. We have to follow their serologies, and that's key. Other changes in the guidelines relate to some details around ocular syphilis and otologic syphilis, specifically around follow-up for these patients and evaluation for these patients. So patients, and again, the highlights are the ones that are highlighted in yellow. So patients who have ocular manifestations of syphilis or otologic manifestations of syphilis, those tend to be ringing in the ear, maybe change in hearing. for both of these manifestations of syphilis, as long as the person has a normal neurologic exam and they don't have cranial nerve abnormalities or other evidence of neurologic involvement, they do not need to have a lumbar puncture. And that's because the lumbar puncture often for ocular syphilis and otosyphilis is normal. And the prior recommendation was to get that lumbar puncture and treat for neurosyphilis, irregardless of what the lumbar puncture found, what the findings were on CSF exam. And so now the CDC has shifted to say and recognizes that the sensitivity of CSF evaluation for ocular syphilis and otosyphilis is very low. And so you will just treat for ocular syphilis and treat for otosyphilis. You don't need to do that lumbar puncture. And all of these patients who have ocular manifestations should be seen by an ophthalmologist. And this is only in the case if they have no cranial nerve abnormalities. Moving on to another change in terms of syphilis follow-up. So in pregnancy, and it sounds like in Arizona, you are dealing with the challenge of having more cases of congenital syphilis, which is why screening in pregnancy is so important. What you're looking for when you're screening and doing follow-up serologies is you don't want to see a fourfold increase in titer that's sustained for more than 2 weeks. But the CDC has clarified that when you're making a diagnosis of syphilis in pregnancy, if the woman was diagnosed and treated and she is at 24 weeks gestation or before, you would want to get a repeat RPR. You want to wait 8 weeks, unless she has a relapse of her signs or symptoms. You don't want to get a repeat in 1 month. That's just too short of a time period to assess for any change. And in a woman who is diagnosed and treated with syphilis in pregnancy, if she's more than 24 weeks gestation, say she's 30 weeks gestation, you would get that repeat serology at delivery. And just to recognize that in pregnancy, many patients will not achieve that fourfold decrease in titers before delivery. It's going to take that 12 months possibly in early syphilis and maybe out to 24 months in late syphilis. So just to realize that what you're assessing for is the drop, but what you really don't want is the rise in titer. That's the thing that is concerning. All right, I know this is a lot of content. We're going to shift now to herpes. And again, no treatment changes for herpes, but there is kind of greater content around serologic testing for herpes. And so for herpes, we have always known that the test that we use to make a diagnosis of herpes with a serology was not very specific, meaning that you could have false positives. And that is why CDC has never said, to test everybody for herpes with a serology. The CDC has specific guidance around who should get a herpes serology. And I'm just going to read through kind of what that guidance is because I don't have a slide on that. And basically, the populations that you want to screen using a type 2 glycoprotein G serology test for herpes are those who have recurrent or atypical lesions that are concerning for herpes in the genital area. Those who you have made a test for herpes, like with a PCR or culture, and that test was negative. Those who have clinical lesions, but those lesions have never been laboratory confirmed, or those patients who have a partner who was recently diagnosed with herpes 2. These are the patients that you would consider getting a herpes 2 serology in, but realize that you can have false positive results, particularly in these tests, these EIA tests or CIA tests, if you have a low index value. And so this is a mini algorithm. And so if the test result on the lab report comes back and it says HSV2 EIA CIA index value less than 3, that means that these are somewhat indeterminate. And what is recommended by CDC is that you need to get a second test. And the 2 tests that you can use are either the BioKit, which is a point of care test, or the herpes 2 Western blot test. And that test is actually a send out test through the University of Washington. It's somewhat costly and it's kind of labor intensive. But this is the guidance as of right now. Someone who comes back with a herpes 2 test that is 3 or greater, confirmatory testing is not required, but providers need to be aware that you can have false positives in both scenarios. And so patients should be counseled about the limitations of these tests before doing these tests. And healthcare providers need to know that the specificity is only about 39%. If the index value is less than low. And so very high rates of false positive results. And there is even a chance of false positive results if the herpes index value is 3.0 or greater. The other thing that is in the guidelines, this is kind of not new, is just information around the fact that IgM serologies are not recommended. And that's because you can detect IgM HSV2 in patients who have recurrent lesions. And so it's not an indicator of new infection. And that in those who have had, say that you're seeing somebody sex with a new partner, this partner told them they've got herpes, they want to know that they've been infected, you need to wait at least 12 weeks because it may take up to 12 weeks, sometimes even longer, for them to develop antibodies and for you to be able to detect them in serologic testing. All right, we're getting to the end of the presentation. We're going to move on now to vaginitis. And so let's get this poll here. We have a cis female who presents with this frothy green discharge, and you see motile trichomonads on her wet mount. What would you treat her with? Do you want to give her metronidazole 2 grams, metronidazole 500 milligrams twice a day for 7 days, tinidazole 2 grams, or metronidazole gel? And let's get you guys to respond. And if we have enough responses, maybe we can see our poll results. All right, so 66% of you got that correctly. So you are up on what the 2021 treatment guidelines are recommending. That's great. 21% said that giving the stat dose of 2 grams, that was the prior recommendation. But highlighted here, this is what the CDC now recommends for TRIC. It's that longer duration of treatment, 500 milligrams twice a day for 7 days, and we'll just go follow through and discuss why that is now recommended. And so there recently was a randomized controlled trial to look at whether all women needed to get this longer duration of therapy. In the 2015 guidelines, it had been recommended that persons living with HIV get that longer duration of treatment, and that was based on a prior trial that was only done in persons living with HIV. But this new randomized controlled trial by Patricia Kissinger assessed 623 women. They were randomized 1-to-1 to either get the single dose or get the longer duration, the metronidazole, for 7 days. And then they were assessed with a culture tested cure at 6 to 12 days post-treatment. And this is showing you what the results are. And so there was a higher rate of cure at follow-up in those women that had the 7-day treatment. It was 89% cure versus 81%, and that was statistically significantly different. And so the CDC is now recommending in the 2021 treatment guidelines, when you're treating vaginal TRIC, whether the person is living with HIV or HIV uninfected, you want to use this longer duration of treatment, the 500 milligrams twice a day for 7 days. Partners or men who are being diagnosed with TRIC, they are still recommended to get the 2 gram single dose, and that's because we have no data on this longer duration of treatment in that population. And this is now consistent with what ACOG, so ACOG is the American College of Obstetrics and Gynecology. They also updated their treatment guidelines for vaginal TRIC, and they now are recommending metronidazole as well. The other update in the metronidazole in the section on vaginitis, as it relates to using metronidazole to treat BV and to treat TRIC, is that we'd always said, you can't, have your glass of wine or have a beer when you're taking Flagyl. You would be worried about side effects. But we actually, there is some new data that demonstrates that metronidazole does not actually inhibit the enzyme that metabolizes alcohol. So it's not like disulfiram where you get that anabuse effect. And so refraining from alcohol is no longer necessary, and that's what's in the 2021 treatment guidelines, and that's based on a study that's cited at the bottom of this slide. And then finally, in the BV section, there are some updates on some new tests that are available for BV, so bacterial vaginosis. You can still use a wet mount. That's a great way to make a diagnosis of BV. You see the clue cells. So those are still useful and a lot less expensive, but if you have access to one of these 2 tests here, these tests have decent sensitivity and decent specificity. They're the BD Max vaginal panel or the Aptima BV. In terms of treatment for BV, there are no changes in the recommended regimens. And so if you see here, 500 milligrams twice a day for 7 days, that's the same treatment that we now are using for TRIC. And so we now have one medicine that can treat TRIC, and it also can treat BV, which is very nice and very useful. But there are some changes in terms of alternative regimens. There's one new alternative that is recommended in non-pregnant persons. That's called secnidazole. I think it's somewhat pricey, and these are granules that you actually have to be sprinkled onto yogurt or pudding and then drink a glass of water to kind of aid in their ingestion. And there are two new topical regimens that also have been added. So we have a whole host of regimens that can be used for BV. And then in the yeast section, the vulvovaginal candidiasis section, the main change, it's highlighted in yellow on the slide, is that I think there's more emerging data around fluconazole, and that we don't want to use it in pregnancy when we're treating yeast. There are some data that it might increase congenital anomalies, spontaneous abortions, and so we want to use our topical azoles. There are a whole host of topical treatments for vulvovaginal candidiasis that can be used. And then I'm just going to complete my presentation just to share test of cure recommendations versus retesting recommendations. And so test of cure recommendations, we already talked about one of them, and that is that we do a test of cure to make sure that the medication that we're using was effective. We're looking for treatment failure. And there now is this routine recommendation to test all patients who are being treated for pharyngeal gonorrhea. We want to test them 2 weeks after, and this is in all patients. There has always been the recommendation to do a test of cure for in chlamydia at 4 weeks. We talked about that. What's new is LGV. We didn't really mention LGV is caused by a strain of chlamydia, and the mainstay of treatment is with doxycycline. However, if you're used as azithromycin to treat LGV, CDC is now saying you might consider getting a test of cure at 4 weeks. We talked about genitalium, how you start with doxycycline and then use moxifloxacin. If you end up using the alternative regimen, you'd want to get a test of cure as well. And then retesting, this hasn't really changed, but I'm just going to reemphasize it. And that retesting, we're looking for infections that are reoccurring, reinfections at about 3 months. And so retesting is done because we have data that demonstrates once you've identified a population that has gonorrhea, chlamydia, or TRIC, we know that this is a population that is higher risk for having these infections in the future. We have data around that. And so the CDC basically says we want to retest these patients, these persons at 3 months, or any time in that 1 to 12 month window is fine. And I think that I'm at the end of my presentation. I just want to alert you to the STD-CCN, which is a great resource. If you have a complex clinical case that you want a consult on, the CDC funds this. This is a warm line. It's not a hotline, and you'll get a response within 1 to 5 working days. It's a website. You can put your question in, stdccn.org. That is a great resource to all of you. Other resources, the treatment guidelines. This is the link to them again. The National Network of STD HIV Prevention Training Centers. My center, the California Prevention Training Center, is a part of this network. And then we have the National STD Curriculum, which is a great resource. Lots of detail. They actually have updated all of their content to be consistent with the 2021 treatment guidelines. And so if you want more detail about any of the content that I've shared with you today and don't have time to ask it the question, this is a kind of an ongoing resource that's continually updated. And I want to thank all these folks on this slide because I utilized some of their content in my presentation. And I think now we have time for questions.
Thank you so much, Dr. Adler. If you could stop sharing your screen, I have put all of the questions we've received so far in the chat in a Word document. If it's easy for you, I'll just share my screen and show that so you can read through the questions and answer them however you'd like. Does that work for you?
Yes, that's totally fine.
Can you see the questions?
All right. For those of you who test in ER settings, under what circumstances can we use IV versus IM ceftriaxone? So I'm assuming this question relates to treating for gonorrhea. And my understanding is, and this would be a question for a pharmacologist, is that the the absorption is different. And so that in general, I believe you want to use the IM for ceftriaxone, but I would have to confirm that with a pharmacologist. And so for whoever put that in, I know that we have received that question before once, and I'm not quite sure on the answer to that. I believe you want to use IM. It has to do with the pharmacokinetics of ceftriaxone. But depending on how long you have the IV in for, it may be fine. But if that person could send me an email, and maybe Becca or Britt, if you want to put my email in the chat. I don't want to get a ton of emails, but I'm happy to answer that specific question. I mean, I can take emails, but I'm happy to answer that specific question because I know I'd want to consult with our pharmacologist.
Yeah, I can connect you to Sean, who asked that question.
Great. Thank you so much. The next question, what are the biggest challenges of the treatment of populations that are homeless and are... Yeah, the challenges of patients who are being seen in an emergency room. That is a population, and in the guidelines, I think that there is content in many of the sections that basically says if follow-up is a concern, then oftentimes you are going to presumptively treat. And so that is particularly true for patients who are presenting with, manifestations of cervicitis, urethritis. I'm assuming those are the ones. We're not really going to presumptively, we would also presumptively treat sometimes for syphilis. If someone presents with clinical lesions we think that look like syphilis, presumptive treatment definitely comes into play. All right, next question is, you mentioned that 6-month RPR drop with neurosyphilis is in relation to spinal tap, so the guidelines support rechecking RPR at 6 months. So in terms of the recommendations around LPs and patients who are being treated for neurosyphilis, the guidance is that follow the RPR, follow your serology. As long as that remains low and drops 4-fold, you do not need to get a lumbar puncture. If it rises 4-fold, it's a sustained rise 4-fold, that would be something to consider a lumbar puncture. But the guidance has shifted. You don't need to get follow-up lumbar punctures in patients who have been treated for neurosyphilis appropriately, as long as you can follow their RPR. That was question 3. Let's see, question 4. Now this is that just for HIV? It's hard to know what this was related to. The stat dose for others.
That one came up right around the time of the last poll question.
Yeah, so for TRIC, I'll just review what the standard treatment is. For trichomoniasis, the standard treatment is now persons living with HIV and persons who are HIV uninfected. It's the 500 milligrams twice a day for 7 days. And so it's not a stat dose. The stat dose is really only for partners or if you're diagnosing TRIC in male patients. LGV is lymphogranulum venereum, which is an STI that is caused by a specific strain of chlamydia. And most patients, if they present, they may present with proctitis manifestations, proctocolitis manifestations. And there's a whole section on LGV in the treatment guidelines.
Becca actually linked those and answered that question in the chat. So
perfect. Okay.
Yeah, she's been doing great at catching a lot of these questions. So questions 7 and 8, I already put Becca's answer in there. So that's why those are in. So
all right. Yeah. So so the 7-day window in terms of treatment for latent syphilis, the CDC guidelines is that you have 9 days, and that's what Becca has put in there. And so you don't have to repeat, and this is per the CDC, if it's less than 9 days between doses. And in non-pregnant persons, you see, Becca has put that in as well. If the interval of 10 to 14 days may be okay. I know that different states may have different recommendations around this. 7 to 9 days is ideal, but out to 10 to 14 may be okay in a non-pregnant person. I like question number 8. Is there more information about what is meant by the CDC fifth pleasure in sexual history taking? Okay, so that actually is not, I should have clarified that. That is not in the CDC treatment guidelines. That is something that in California and the California Prevention Training Center that would have put in. And what that is indicating is that we're trying to assess, there's the aspiration when you're taking a sexual history to assess about kind of all the challenges that your patient, all the behaviors that your patients are engaging in, but you may also want to assess, are there any Are they having pain with sex? Are there any other issues that might impact their capacity to have pleasure with sex? And it's not a CDC recommendation. It's kind of more of an aspiration if you have time to assess further about any other issues that may be impacting their capacity. Maybe are there any functional issues that they're having with their sexual acts that might impact their capacity for pleasure. So that is the information that we're trying to find out. Are there any functional challenges?
And then I added question number 6 that just came through in the chat. And I do want to let everyone know we have until 10:30 with Dr. Adler. So if you have questions or if you'd like her to speak a little bit more on some of these topics, drop it in the chat because we do have time.
So the question about why do we only screen for gonorrhea at the pharynx and why not for chlamydia, that is a great question. We often get that question. And the reason is there has been studies that have looked at patients who have been screened for pharyngeal chlamydia, and the prevalence of it is extremely low. So we just don't have data to demonstrate that this is an infection that is at a point that we need to screen for it. And we know also at the same time that most diagnostics, these infections are linked. So your results are going to come back gonorrhea positive, chlamydia negative if you screen with a pharyngeal swab. If you see on that pharyngeal swab that they have chlamydia, then you obviously are going to treat it. We just know that the prevalence of it is extremely rare. And so there's no recommendation to screen for it, but your tests are going to probably test for it unless you can somehow delink them. And my understanding is that most labs are going to test for both anyway. Hopefully that answered that question. I don't know if you want to.
Yeah, that's all I have for questions from the chat, but I welcome other questions. Okay, looks like we just got another one. I'll drop that in here for you. Can you see that?
That was the same question that you just gave me before.
Oh,
this
sorry.
is great. Thank you so much for doing this because it's always hard to get all these questions off the chat. Yeah, you put the same.
Yeah.
That's okay.
Sorry, looks like someone raised their hand. If you could put your question in the chat, that would be the easiest way.
I think somebody had a question. Let me see if I can open up the chat. Okay. Someone had a question. When treating empirically for chlamydia with 7 days of doxy, if the test is negative, do you recommend that the patient finish out the full 7 days or okay?
That's what I was trying to paste.
So I'm So you are talking about the scenario where someone presented with, say, urethritis, you gave them empiric treatment to cover for chlamydia, the test is negative. Yeah, if the test is negative, you don't need to complete this full 7 days. It would be fine to stop that. Yeah, if their test is negative and say they only had gonorrhea, you've already given them treatment for gonorrhea. Yeah, you would not need to complete that. Our tests are very good for chlamydia and gonorrhea. We should be able to trust them. Question about BioKit. Yes, BioKit should be commercially available. And the only other test, so the question was, is BioKit commercially available, or do you know if any other labs have a confirmatory test for herpes? The only other confirmatory test is the one that's at the University of Washington, which is the Western blot. And as I said, it's challenging a little bit logistically to get that test done, but there are patients who are willing to go through that challenge if they really, really want to know. So if you have somebody who's like, I really, really want to know if I've got herpes 2, I don't trust my test results in this, this serology, I've heard that it has false positives, then I would use the Western blot from the University of Washington or use the BioKit, which is a point of care test that is commercially available. Let's see. Have I been privy to any discussion about new changing treatment recommendations for antiviral resistant strains of herpes? I actually have not been privy to that, and my understanding is that it's really only in persons who are living with HIV who are on antiretroviral therapy where there is concerns about resistance to like acyclovir and all the famciclovir. At this point, I don't know if there are any new regimens. If you want more information on that, I'm in contact with a national expert on herpes, and I can, reach out to her and see if she has been privy to any discussions. So again, Britt or Becca, if you want to connect me to that person, I can put them in touch with somebody who would probably be better able to answer that question.
Yeah, we can do that. Thank you.
All right, so is a rise in RPR 1:1 to 1:2, for example? So you're raising a great question. Our tests for syphilis, particularly the RPR, because it's not a specific test for syphilis, the RPR test is detecting an inflammatory antigen that can be elevated in other conditions. We can have fluctuation of titers. And so when we're looking for an RPR titer change, we're looking for a 4-fold change in titer that is sustained and remains high for more than 2 weeks. So if a titer was 1:1 and then it increased to 1:2, that would be within lab error. That is not considered a significant change or rise. If you wanted to, you could follow it, a month or two later and see if it dropped back to 1:1 or it just stayed at 1:2. But 1:1 to 1:2, we basically say that's no difference. A 1:1 to a 1:4 that then remained at 1:4, that would be a 4-fold rise. Thank you for that question. Let's see, I'm just looking at the chat now. In monitoring adequately treated patients who began with low titers. Yeah, so your great question, Nisia. So these are patients who are being treated for latent syphilis, who start with really low titers. Maybe they start with like a 1:2. Their titer is less than 1:16. We just know that those titers, they don't really have very far to drop. If you start with a 1:4, you have to go to 1:1, or if you start with a 1:2, you don't really have very far to drop. And so, yes, there is data that demonstrates these titers may not drop 4-fold, and kind of each patient individually at 24 months out, you can assess whether you want to do any more treatment to see whether that would make their titer drop. And in many patients, we just follow their titers and make sure they don't rise 4-fold, as long as they have gotten standard treatment for syphilis. Yes, so if someone is raising this really important point, can you please emphasize the critical need for day of treatment titers? This is really, really important. Thank you, Glenn, for that. So the reason, because with syphilis, we're monitoring RPR titers at specified time periods after treatment, and we're trying to see, has that titer risen 4-fold? Has it dropped 4-fold? We want to get a titer on the day the person starts treatment, and oftentimes you have somebody, maybe you think they might have secondary syphilis, they have a rash. You get a test on them, and it turns out it's syphilis, but you didn't treat them the day that they had the rash, and you got a titer on them that day. They come in 2 weeks later, you start their treatment. If you don't get a day of treatment titer that 2 weeks later, you don't know where their titer is the day that you're starting treatment. And so it's really important to get a day of treatment titer. That way you have a titer at the start of treatment, and that way you have a starting point to assess, has that titer changed, or has it dropped 4-fold at 6 to 12 months? Has it risen 4-fold? So it's super important. Thank you so much for bringing that up. Let's see. Next you have on here on EPT for gonorrhea and chlamydia, the slide says previously only recommended for hetero men and women, now shared decision-making for EPT. What about other partners or multiple partners? Yes, so when you're giving expedited partner therapy to a patient, the standard practice is to offer to all of their partners, or all of their partners that are not going to come in and get tested themselves and have an evaluation. So EPT in general is kind of a second line strategy. The first line is always to say, have your partner come in with you, because it's always best to get those partners in to assess them and test them. But so EPT should be used for all of those partner, or whether it's more than one, who are not willing or able to come in to be seen and given treatment. Great question. Oh, thank you, Rebecca. You put in a lot of your STI guides. And I think that there's one new question. Oh.
I'm not seeing any. Oh, there's a new question. I do want to mention too, if there are questions for Becca on the slides that she presented, now would be the time to ask those as well. Are you seeing this question, Dr. Adler?
Let me look and see. And some of these RPR questions, let's see. Day of treatment RPR is 1 to 32, and at 6 months it's 1 to 2. Then at 8 months it's 1 to 8. Is this considered reinfection? So if the person had a 1 to 2 and it was 6 months out, their titer had dropped appropriately. At 8 months, if it was 1 to 8, at 8 months, what we'd want to assess is this person, sexually active? Have they had sex since their prior titers? If they're sexually active, and then we would want to repeat that 1 to 8. So we often get these questions through STD-CCN, and in the guidelines, you'll see that it says a sustained 4-fold rise, and that's because titers can fluctuate. And so what my guidance around this would be is you would want to repeat that 1 to 8 and make sure that it remains. And if it remained at that, then we would be concerned about reinfection. And we'd want to do a good head-to-toe exam on that patient, make sure that they have no neurologic signs or symptoms, make sure they don't have a hidden ulcer somewhere. And these are all in patients who are continually to remain sexually active. If the person, had complete abstinence, no sexual encounters, then we'd be concerned possibly about treatment failure. But you are referencing that 1 to 2 titer, so yes. But the important thing is that you'd want to see the titer that has risen 4-fold, and it has to be sustained, because sometimes you get a blip up from something completely unrelated and it blips back down. So I always tell people to repeat it again in 2 to 4 weeks. So the question, how far out would you retest the titer in the scenario? So the guidance around the CDC is it depends on what the person was staged with syphilis. And so for primary, secondary syphilis, you want to follow titers out to at least 12 months to see if that titer drops 4-fold. In persons living with HIV, you might have to follow out to 24 months. And then you're going to follow their titer at least annually, but then you're going to follow that titer based on what their risk is. So if it's someone who is a male who's got male partners and they fit into the category of being higher risk, maybe having anonymous sex partners or multiple partners, those patients should be followed every 3 to 6 months. And so you not only are just following their titer because of having prior syphilis, you have to be following their titer because based on their current sexual activity. I think I answered that one.
It looks like we have time for this last question that I'm trying to copy and paste. Apparently Zoom doesn't
I can
like
see it. I can see it. So I
Okay.
want to test for genitalium. How long after initial treatment for gonorrhea to treat persistent urethritis that fails initial treatment? Also, okay. So basically the recommendation on testing for Mycoplasma genitalium is patients who have persistent urethritis, and you're going to know who those patients are. So those are people who, like I presented a case scenario on this. These are people who have urethral manifestations, discharge, dysuria. You treat them often presumptively. If you're not working in a clinic where you can do, rapid tests or a gram stain, you're going to treat them to cover for both gonorrhea and chlamydia. And then they will come back to you if their symptoms have not resolved. There's no routine recommendation to do a test to cure in someone who you're treating for urethritis, and you will get their test results back. And if their test results show, didn't have gonorrhea, didn't have chlamydia, they're probably going to be coming back to you. And in a male patient who's got male partners, the primary thing to think about is MGent. In a male patient who has female partners, you might also want to think about trichomonas. And there are NAT tests for trichomonas. And so those are the patients that you probably are going to want to test for MGent and test for trick if they have female partners.
And it is 10:30, so I want to respect everyone's time and honor our agenda here and move to our first break of the morning. If you have additional questions, and I see that one just came through, I can connect you with Dr. Adler via email. And I just want to say thank you to Dr. Adler and to Becca for those excellent presentations this morning. We will resume presentations at 10:45, so please feel free to take care of yourselves, grab coffee, water, whatever you need, and we will start back at 10:45. It's 10:45, so I'd like to go ahead and move along with our agenda this morning. I think folks might still be joining or coming back from break, so we will slowly transition into our next presentation, which will be led by Max Short from the Arizona Department of Health Services. So Max, if you would like to pull up your slides and get settled and get ready. While you do that, I do want to say a couple of things about the organizations who put this presentation, or I guess put this whole event together, I should say. I didn't mention this at the beginning. I know that folks were joining, and so I wanted to wait until everyone was settled just to acknowledge the California Prevention Training Center. Dr. Adler represents that organization, and I think we can all agree that that was an excellent presentation. Later today, we will hear from, we'll hear on tuberculosis, but I should say that the folks who helped make that portion of today's event happen are with the Curry International TB Center. And then I didn't introduce myself. I'm the one who's been sending a lot of you emails. My name is Britt Nigan, and I'm the program manager for the Pacific AIDS Education and Training Center for Arizona. And in a minute, we will hear from Dr. Fantry, who's our medical director. So the three of those organizations worked in collaboration with the Arizona Alliance for Community Health Centers and the Arizona Department of Health Services to make today's training happen. So I want to say thank you to everyone who's been involved in the planning and everyone giving presentations today. And I specifically want to thank our partners at the Arizona Department of Health Services as I pass this off to Max, who will do a similar presentation to Becca's, where he will give us an overview of the HIV surveillance rates in Arizona. So with that, Max, it's all yours.
Thank you, Britt. Good morning, everyone, and thank you all for being here. My name is Max Short. I'm the HIV surveillance data manager at the Arizona Department of Health Services. And today we're just going to be going over some HIV surveillance data from Trends and 2020. So similar disclaimer, same disclaimer as before. I'm a state employee, so I have nothing to disclose. So by the end of our presentation today, we should be able to describe statewide HIV surveillance data and trends and identify the impact of COVID-19 on HIV testing. So from 1982 to 2020, here's our HIV incidence trend. From the height of the epidemic in 1988, Arizona has seen a 16% decrease in our number of incident cases. So 2020, we had 680 incident cases. You can see that decrease, that marked decrease in 2020. That decrease compared to 2019, when we had 755 cases, may be due to the COVID-19 pandemic. And we'll touch on that a little bit more when we look at COVID-19's impact on testing. So we're going to go through what I like to call the big four demographics. So we have our 2020 numbers based on our race ethnicity. We see that Hispanics make up the number one spot with 275 incident cases, followed by white, followed by Black African American. For our age breakdown, 25 to 29 is our highest for incident cases with 140, followed by 30 to 34 and 20 to 24. And that is pretty similar to what we see with the STI, with the rest of the STIs as well. This isn't probably a huge surprise. Males make up the lion's share of our cases, and this is a similar trend each year. Females is a much smaller proportion of our cases, with only 89 compared to 591 for males in 2020. By risk, again, not much of a surprise. Men who have sex with men make up the lion's share of over 50% of new cases in 2020, followed by no reported risk, followed by a combination of men who have sex with men and IV drug use. And now kind of the more interesting portion is looking at HIV testing and the impact that COVID-19 had on it. So comparing 2019 to 2020, we see a serious decrease in the number of tests. And these numbers are from our HIV prevention program. So these are testing numbers from clinics that are funded by our HIV prevention program. So we see kind of starting in March and pretty serious in April, comparing 2019 to 2020, that drastic decrease in our number of HIV tests. Pretty much for the rest of 2020, we see a pretty serious decline in the number of testing. There was about a 33% decrease in our publicly funded testing in 2020 compared to 2019. 2020, there were about 39,000 tests performed, whereas 2019, there were about 59,000 tests performed. However, the number of home testing kits requested were up by 44% in 2020. So it seems like there were more people interested in that home testing, and that's due to HIV-related services being disrupted or halted entirely, including things like testing and outreach, partner services, field investigations, that sort of thing. Also of note that the majority of the decrease in testing was of initial tests, so screen and confirmatory tests. Tests for those viral loads and CD4 that you get from more regular follow-up of people living with HIV were not as impacted as much. So it seems like for the most part, there was a barrier. COVID-19 caused a barrier for initial testing as opposed to testing for those who are living with HIV already. And finally, we have our care continuum. So that's 16,602 were people living with HIV diagnosed prior to 2019. The 12,825 were receipt of care, so people who had one or more labs, whether that was a viral load, a CD4, or a genotype, within 2020. The retained in care, which is a 55.6%, were those who received two or more labs within 2020. And then, of course, our viral suppression, which is an important number for us at 68.7%, are those whose most recent viral load in 2020 was 200 copies per milliliter or less. Not included on the slide, but still a number to note is 80.7% of all individuals who were newly diagnosed in 2020 were linked to care within 30 days of their diagnosis. And with that, anyone have any questions, you can email me, or if you have any requests for data, please feel free to email me as well.
Thank you, Max. There are a couple of questions in the chat. I think you finished a few minutes early, so if you want to address them now, you can. Otherwise, we can address those at the end of Dr. Fantry's session as well. Are you able to see those questions?
Yes. Let's see. Representing infected, but I am curious if those are infected undetected members, infected treated, infected untreated. So those are the numbers that I'm representing are just numbers that are infected with HIV. Possible that they have co-infections with other STIs, but those are just representing HIV numbers. Does that answer your question?
I think it does. And just so you know, the participants are not able to see the question. So if you could read the question before you answer it, that gives some context.
Sure. How does demographic distribution of HIV compare to demographic distribution in Arizona in general? I'm from the Midwest, so I'm just wondering. Yeah, so Hispanics make up a large portion of Arizona's demographics. The incident numbers are pretty in line with the breakdown of demographics in Arizona. And that's true. That's true for the race, ethnicity for sure. Age is a little bit tricky, and it kind of swings depending on the time of year, the age breakdown in Arizona. But for demographic, for race, ethnicity for sure. And then did the data showing number of tests in 2020 include home tests or just in-office tests? That included just the in-office test. The home test numbers are not included in the testing data.
I'm not seeing any other questions. So if anyone else has questions, you can put them in the chat. I think Max might be able to stick around for a little while. And I think we can move to Dr. Fantry's talk then. Thank you so much, Max. That was really informative. So thank you for putting that all together. And Dr. Fantry, if you're ready to come on and share your screen, we are ready for you.
I am ready. Let's just get my slides up.
While you do that, I will do just a brief introduction, and you're welcome to add anything to this, Dr. Fantry. But if you scroll to the second page of your agenda, you can read her full bio. I wouldn't be able to do that justice in a brief introduction, but I will say that Dr. Fantry has been providing HIV care for I think at least 30 years. She is our medical director for the Pacific AIDS Education and Training Center for Arizona. And we are so fortunate to have her expertise and also her skill in sharing this information. Our program is located at the University of Arizona within the College of Medicine. And so Dr. Fantry is teaching faculty there, and she also sees patients. She sees a lot of patients, and she's able to share a lot of that practical knowledge in these presentations. And so with that, I'm going to pass it off to her. Thank you so much, Dr. Fantry. Just like in the previous session, if you have questions throughout the presentation, please put them in the chat and we will address them all at the end of the presentation.
Thank you very much, Brett, and thank you everyone for joining us here today. I'm extremely excited to be talking today because we now have new PrEP guidelines that came out at the end of 2021. And they really have three things that I think are extremely important. One, they talk more about inclusiveness, especially women. They also address some of the practices that many of us have been doing for the last few years but haven't been formalized. And they discuss cabotegravir, which is a new addition to the medicines that we can use to prevent HIV infection. So right here is the disclaimer that everyone has said, and basically these views are my views and opinions today, and they're not necessarily those of the US government. However, the discussion today is primarily based on the CDC guidelines. I have no disclosures. And the learning objectives today are: one, to identify new recommendations on who to consider and monitor for PrEP in order to prevent HIV infection. Compare and contrast regimens for PrEP discussed in the updated PrEP guidelines to improve patient treatment outcomes. Okay, so what is PrEP? This seems like a pretty dumb question, but we surveyed the Pima County Health Department patients in 2017, and only 20% knew that what PrEP was, that there was a medicine existing to prevent HIV, and only 12% of women in those clinics knew. So it still is somewhat of a mystery, okay, to some people, but I'm sure in this audience you have a good understanding what PrEP is. You're giving medicine to a person that's not infected with HIV to prevent HIV. And it's antiretroviral therapy, not in the same amount, but it is still antiretroviral therapy. And these are some of the pharmacokinetics that I'd like to show. This is actually for our oral drugs, okay? It's not for cabotegravir, but as you see, it's pretty efficacious. You take 99% effective if you take 7 doses. And even if you go down and only take 2 doses per week, it's 76% effective. We don't recommend that, but indeed, it's pretty efficacious. Women, it's a little harder to get levels in the vagina. So you really need to take that 6 to 7 doses per week to have it work. And it can take longer for women to actually achieve adequate levels to prevent HIV. So the first drug that came out is tenofovir disoproxil fumarate with emtricitabine. And this was approved, believe it or not, 10 years ago. And uptake was pretty darn slow, but it has increased, not nearly to the levels that we like. And it is indicated for everyone who's high risk of HIV. And now generics available. It's been available for about a year now, so the price has come down substantially. And just to put a little, I guess, spice in the game or whatever, the new PrEP guidelines have used new initials for emtricitabine. Instead of FTC, it's now labeled F in the guidelines. TDF's the same. Throughout this talk, I'm going to refer to emtricitabine and tenofovir disoproxil as TDF and FTC, the old abbreviations. And the old by meaning in the guidelines, they're still really used in many of the articles you read and any information you receive. And then we had a new drug come out. October 3, 2019, we had a new form of tenofovir combined with the FTC. And this is indicated though only for people assigned male at birth. And this includes transgender women. It's not for people assigned female at birth or transgender men because there weren't enough women in the trial. It was really a trial of MSM and males. Okay, so then we have another agent, and this is the exciting new agent that just came out, FDA approved for treatment about a year ago, but now it's actually FDA approved for prevention of HIV. And again, indicated for everyone, like the old form TDF and FTC. Given as 2 injections, 1 month apart initially, but after that, a person doesn't need an injection until 2 months are up, which is very nice. You don't have to take pills every day. The downer is it does have to be done at a pharmacy or a clinic, so a person can't give the injections at home. And it actually is even more efficacious than tenofovir disoproxil fumarate. If you look at this data here, you see the slide. So actually this is cabotegravir and this is TDF and FTC. And as you note, less infections with the cabotegravir. So it is definitely a good option for people considering PrEP. So who's a candidate for PrEP? So this is really hasn't changed, but adults or adolescents, I just remind you that adolescents can have PrEP. They have to be at least 77 pounds though. And anyone who's had anal or vaginal sex in the past 6 months with a partner and any of the following should be considered for PrEP. So basically the real indicator is if you have inconsistent or no condom use with sex partners and you don't know their HIV status. And bacterial STI in the past 6 months. That's also an indicator that you may indeed be a candidate for PrEP. So the STIs that we consider important for PrEP are slightly different in 2 different groups. So if you're a man who has sex with another man or a transgender woman, we consider gonorrhea, chlamydia, and syphilis all significant STIs. Heterosexual men and women, chlamydia is not included, and because it really hasn't been shown that chlamydia is a risk factor for HIV in heterosexual men and women. So we really look at gonorrhea and syphilis in this group. So we also consider drug users, okay? If someone shared injection drug equipment and this is within the last 6 months. So anyone who shares injection equipment should indeed be offered PrEP. And actually others, you may even discuss it with them because certainly there are always issues with relapse in people who inject drugs. So if your sex partner has HIV, there's other considerations as well. So currently we don't recommend PrEP for every sex partner of someone living with HIV, but there are groups that we do want the person who is the partner of someone living with HIV to receive PrEP. And one is if the partner is not taking antiretroviral therapy or if HIV infected partner's viral load is greater than or equal to 200 copies. So basically anyone that's not on HAART, the person who has sex with them should indeed be on PrEP. And if they're on HAART and that viral load is greater than 200 or 200 copies, the sex partner should be on PrEP. If you don't recommend PrEP for someone, because maybe they're on antiretroviral therapy, their viral load is less than 200, you should have a good documentation that the viral load is less than 200 for at least 6 months. And here's a great graph that the CDC and NIH put out, but it really kind of tells the story. But it takes about 1 to 6 months to achieve an undetectable viral load. And really by this, by this we really mean a viral load less than 200, because that really was the marker used in studies to determine that people with HIV do not transmit the virus if their viral load is less than 200. But anyways, it takes 1 to 6 months, and then we like a maintenance of about 6 months of this level less than 200. And basically, that means there's no risk to transmit the virus to your sexual partner. You equals you. Okay, so I'm gonna flip into some other issues, pregnancy. So it was recommended in former guidelines, but not really emphasized so much to have PrEP if a woman's pregnant. And this is really the realization that, and not so much in this country, but throughout the world, half the people living with HIV are women, and most of these are childbearing age, and many of them don't have a lot of control over their sexual life. So it really is indicated that a woman who is pregnant and is having unprotected sex should actually be on PrEP. There is maybe a slight risk of the fetus, although the data comes out and it really doesn't seem very significant. It does change the risk-benefit ratio, but only slightly. And again, Truvada actually is the drug that we use if a woman's pregnant and has HIV. So again, the risk really seems quite low to the fetus. Okay, I have a case study for you. Megan's a 23-year-old cisgender woman who presents to Planned Parenthood for an HIV test. She is breastfeeding her baby, who is 3 months old. She continues to have unprotected sex with the father of her child. She had chlamydia 4 months prior, gonorrhea in 2014. She's sexually active with 6 men in the past year, but quite frankly, she has no idea what their HIV status is, whether they use drugs, or whether they have sex with men in addition to sex with women. And again, this is kind of classical. Many women don't know this, and the past guidelines were based on these factors. So I'm glad they've updated these. Uses condoms 40% of the time, smokes a half pack per day, drinks alcohol occasionally, but does not use illicit drugs. So what would you do for Megan? Give her cabotegravir, daily TDF, FTC, daily TAF, FTC, on-demand TDF, FTC, none of the above. Okay, we have some results here, great. Okay, so I think the majority of you are agreeing with me. So I would give daily TDF FTC. Some people mentioned giving daily TAF FTC, but actually, as I said, TAF and FTC is not actually recommended for women. The data is only in men, okay? So we wouldn't want to give it to this woman. Cabotegravir may be an option in the future, but there's really not enough data on women who are pregnant and women who are breastfeeding. And I'll talk a little bit about that. On-demand TDF FTC, that I'll talk about later, but again, only approved in men who have sex with men. We don't really have any data in women. And then none of the above, interesting. I think I'd give her PrEP. But, you know, people, you know, maybe even discuss it with her. Because I can't count the number of people that we see at the health department that come in with syphilis, and they're women. And that certainly puts them at high risk for having HIV. Okay, next slide. So this is just to explain the cabotegravir in pregnancy and breastfeeding. So basically the bottom line right now is you don't have enough data. It's possible in the future, but there's a little issues because cabotegravir, there's some delay in diagnosis of HIV. We don't really know what amount of cabotegravir gets into the breast milk. And with cabotegravir, it's highly, highly, highly efficacious, but there is some issues with drug resistance when someone gets HIV when on cabotegravir. 5 of 9 people in a recent study that had resistance, breakthrough infection with cabotegravir, had resistant virus to cabotegravir. And that's one of the big drugs, or it's a class of drugs that we typically use, the integrase inhibitors to treat HIV. And then there is maybe an issue of weight gain with cabotegravir. Okay, but we do think cabotegravir will be great for some populations. It may reduce the stigma of being on PrEP. You're not taking a pill every day. And also people that may have difficulty with adhering to a pill every day. Adolescents, if you're homeless, substance use disorders, cognitive impairment. And it's really akin to directly observed therapy that we use for TB. You actually see the person and get the treatment. The big factor right now is price, okay? It still is not nearly as low in price as TDF and FTC. So hopefully that price will reduce, or we'll get some way to pay for these groups, because as you see, these groups are not typically able to pay these high prices. Okay, so what do you want to do prior to starting PrEP? There's a lot of lab work, especially for daily, which would be the TDF, TAF, imtimcidabine, FTC combination. And there's a little less with cabotegravir, which is nice. So when you're starting a daily PrEP, you do want to get an antigen antibody test, 4th generation test, which would reflex to antigen and antibodies. And then if both are negative, they will do a PCR. Cabotegravir, you should get the 4th generation test, but I do want to note that it's also recommended in part of the guidelines that actually you also would do an HIV RNA, even if that HIV antigen antibody test is negative. And that's because, again, there's this really long tail with cabotegravir. It stays in your body for 2 months or more. So we really want to make sure we're not giving someone a drug that prevents HIV and then only giving them a single drug to treat HIV, which produces resistance. We also want to do hep C testing, okay? And these new guidelines, and that's for both groups, these new guidelines do recommend it only for MSMs, transgender women, and people who inject drugs. That's because the risk of getting hep C with heterosexuals is really nil. Okay, heterosexual contact doesn't do it. However, having said that, just for routine health maintenance, everyone in the United States between 18 and 75 should be tested at least once for hep C. Syphilis, both groups should get syphilis testing, gonorrhea testing, and chlamydia testing. It's recommended that both groups get this, except men who have sex with men get the gonorrhea and chlamydia. Heterosexuals, both groups would get the gonorrhea and testing. And it's indicated at all sites of contact, so rectal, urine, oral, and or rectal, as indicated. Okay, so prior to starting PrEP, there's a lot of things in the daily category, and there's no more in the cabotegravir category, which is great. Hep B testing, you can get it if you have a patient on cabotegravir, but not really necessary. And the creatinine clearance is not really necessary with cabotegravir. And I'll talk a little bit about these issues in the next few slides. So HIV testing for oral or cabotegravir, just a few important points about that, because this is really the key test you're getting. It should be done within 7 days of starting PrEP. Okay, if it's been longer than 7 days, you want to repeat that HIV testing. And there's also a few tests that we don't like you to use. One is a rapid oral test. It's less sensitive for detection of acute or recent infection. We also don't want people to be doing patient reporting test results or documented anonymous tests. And we don't also want people to use to actually enroll people with preliminary positive HIV antibody only tests unless a negative HIV status is confirmed. So we really do want to make sure that people do not have HIV. The preferred testing is laboratory blood sample, but you can do a rapid point of care FDA approved finger stick with the antigen and the antibody test. So similar to a fourth generation blood test. HIV testing for daily PrEP. If you suspect acute HIV, you will handle this a little bit differently. You can repeat HIV antibody antigen tests, or you can do a viral load. And note these viral load cutoffs are really quite low. So if the viral load is greater than or equal to 200, it's thought that you have HIV. If it's less than 200 copies, maybe 50, 100, then you want to repeat the test. And of course, if the viral load comes back non-detectable, you don't have HIV. So when do you expect really need to evaluate for acute HIV? And you should evaluate for acute HIV if within the last 4 weeks someone's engaged in exposure-prone behaviors, they have a negative or indeterminate HIV test, and history and physical exam suggest acute HIV. And if you look at this slide, these are the symptoms, signs and symptoms of acute HIV. And they actually, as you see, fever is very common, 75%, fatigue, myalgias. Women tend to get more of the fever and fatigue, and men a little bit less, and men have more of the muscle aches. But in general, these are the symptoms that most people come down with. And then the least common is diarrhea. But I've seen someone come to my clinic last summer, and he had all these symptoms. So it can be a pretty, kind of, I won't say serious because people aren't hospitalized usually with it, but it can make people feel pretty sick. And most people, if you question back within the year, they've had something where they just didn't feel quite right. Okay, so what do you do for oral PrEP if you suspect acute HIV? Again, it's the same thing that I said. We do want to do that antigen antibody test though, preferred over rapid tests. And again, false positives are possible with this. You would repeat it if the viral load is less than 200. Okay, so what do you do for cabotegravir? As I said, it does have a long duration of drug exposure, and it suppresses viral replication, and there is delayed antibody production. So someone may actually have been infected, have a viral load that's detectable, and they still don't have antibodies when they have cabotegravir. So that can be problematic for detecting HIV. And rapid HIV and even the HIV antigen antibody tests often fail to detect HIV. So supplemental antibody tests may be negative or indeterminate, and HIV RNA levels often remain low or undetectable for months. So again, this is the reason why we add on the HIV RNA, even if the antigen antibody test is negative. Okay, so what do you do with that PrEP initiation visit? Well, what we like to do is we have the labs done beforehand, so we can talk to the person about the labs and review those labs. And then we also evaluate for recent exposure to HIV, especially concerned for acute HIV, that they may have contracted it at the time they got their labs done. So we counsel them. Risk behavior reduction and adherence, we do that at all visits, and we prescribe based on the estimated creatinine clearance. Okay, so TDF and even TAF, but mainly TDF, can cause problems with kidney function. We'd like that creatinine clearance to be 60 or greater to give TDF and FTC. The creatinine clearance can be a little bit lower with TAF, as low as 30. And then with cabotegravir, there are no issues related to kidney toxicity. So we really can give that at any creatinine clearance. And that actually is a nice niche for cabotegravir, because someone could still get PrEP even if they have kidney toxicity. Okay, so what are the short-term side effects? So TDF can give you headaches, abdominal pain, actually more in the form of belching or gas, unintentional weight loss. And we think some of this is probably because they're having some abdominal pain, maybe don't feel like eating as much during their first month of therapy. TAF, that can give you diarrhea. So we do get a little bit concerned about that, and we warn people. But again, these side effects tend to go away within the month. Okay, so we're not so concerned about them, just telling the patient they have to get through the first month. Okay, so there are some long-term side effects with TDF and FTC, and I'm sure people have heard about them. One is you can get a small decrease in your estimated creatinine clearance with TDF, FTC, but this small decrease is really clinically insignificant. It doesn't usually progress, and it's usually reversible. And the same thing is loss of bone mineral density. It's small, and it's usually in about 25% of patients taking TDF. It doesn't progress, and it's usually reversible. And again, it really isn't clinically significant. In fact, they've looked at the incidence of fractures on people taking TDF and those on placebo, and there's really no difference. So in a young, healthy person that you're giving PrEP to, this issue isn't really relevant. And I'll show you this on the next slide. If you look at this, so even in older people, this breaks it down to 50 and less than 40. There is a risk for kidney disease or kidney impairment, but it's pretty darn low, okay? The cumulative risk is about 0.07, so exceptionally low even in that group. But then if you look at the less than 40 group, it's extremely low, okay? It's not even 0.01 cumulative risk. So these are really indicators to me that TDF is fine for most people that you're giving PrEP for. We do get more concern in HIV infected patients because people living with HIV do have a risk for osteoporosis, osteopenia, and kidney disease secondary to HIV. So adding on another drug that may cause a problem is not particularly what we want to do. There are downsides to TAF too. So both these tenofovir formulations have unfortunately long-term consequences. This data is from a study where actually what they did is they gave people TDF for prophylaxis for PrEP, and then they switched them over to TAF. And as you see, there's immediate weight gain, okay, in most of these subjects. So they started out less than 100 kilograms, and many went up to as much as 106 kilograms. They stopped the medicine and weight went right back down. So again, this is a concern with TAF. You do have to worry about that excessive weight gain. There are drug interactions with tenofovir formulations, TDF. Most of these are not particularly significant, but they just make you worry a little bit more about renal function, and you may indeed want to check a creatinine clearance sooner than recommended by the guidelines. And you can't give adefovir with TDF. It's basically a cousin of TDF used in the past. It really is used to treat Hep B, and in the past, initially, it was used to treat HIV, but there was too much toxicity at the doses needed for HIV. There are drug interactions with TAF as well. You cannot co-administer with St. John's wort, a medicine used for depression, rifampin, rifabutin, and rifapentine, the TB meds. Also, with cabotegravir, there are some drugs you can administer with St. John's wort again, some of the TB drugs, some other psych meds, and phenytoin and phenobarbital. So for PrEP, you have a 3-month follow-up for PrEP, and you can evaluate at this visit again for acute HIV. That's kind of the key evaluation every time someone comes to clinic. And then you ask them about adherence, and I like to just say, when's the last time you've missed your medicine? And basically that gives people the idea that yes, people do miss medicines. You know, it's common, and it's okay, but you want to get a feel for that. And actually a good kind of indicator in the last week when you've missed medicines. A behavior reduction support. You want to do this at every visit too. Condoms, limiting partners, access to clean needle and syringes and drug treatment services. And as you all know from today, condoms and limiting partners are key because we certainly are in the middle of an STI epidemic here, especially in the Southwest United States, and in particular syphilis, unfortunately. Oral PrEP, a 3-month visit. Okay, so these labs have changed a little bit, but basically it's the same thing with the antibody and antigen test, but at this visit, we still now recommend HIV RNA, so a separate HIV RNA test. And that's again because we don't want people on drugs that actually have HIV. We do recommend behavioral risk reduction support, gonorrhea and chlamydia testing for MSM and transgenders. Okay, so we actually, women, I should say, transgender women. And this we recommend at the 3-month visit. And again, oral, rectal, and urine, same as the initiation. And syphilis for men who have sex with men and transgender women. They're not recommending this at the 3-month visit for heterosexuals, although you should really gauge your screening based on their sexual activity without condoms during the past 3 months. Because certainly a woman could be at risk too, depending on what she's been doing in the past 3 months. Okay, so HIV testing on oral PrEP. So as I mentioned, you're going to do both an antigen antibody test and an HIV RNA. So you're going to need to know how to deal with this. And basically, if you have a reactive antigen antibody and HIV RNA detected, you have HIV, and that's kind of obvious. Same thing if they're both negative, you're going to not have HIV. Non-reactive antigen antibody and HIV RNA not detected, the person does not have HIV. Although sometimes you get these discordant results. So you may have a reactive antigen antibody, HIV and RNA is not detected. You want to repeat that. And the opposite, non-reactive antigen antibody, but HIV RNA is detected. You want to repeat that HIV test. So if HIV RNA is detected on that 3rd test, you actually want to consider that person having HIV. And the same thing, if it's negative, you would consider the person not having HIV. Okay, so at 6 months, there are some labs, and we recommend STI testing for everyone, heterosexuals, and then of course you'd repeat it for MSMs because this is another 3 months visit for them, and transgender women. You do want to assess renal function, and this is only though for people age 50, because if you remember that graph, you see that people over age 50 do have the highest risk. It also could be for a person with an estimated creatinine clearance less than 90, which is really not typical for a younger patient, unless they have other issues, such as kidney disease inherently, or if they have diabetes or hypertension. Every 12 months on oral PrEP, you want to do that estimated creatinine clearance if someone's less than 50, or their estimated creatinine clearance is greater than 90. So we can space out the estimated creatinine clearance testing. Chlamydia screening for heterosexual women and men is recommended in a year, and Hep C testing for the same groups as before, MSM, transgender women, and people who inject drugs. So as I said, if you have hypertension, diabetes, other risk factors, you may want to check that creatinine clearance sooner, even if they are less than 50. We would continue the TDF-FDC if it's only a small decrease in creatinine clearance and it remains greater than or equal to 60, and the decline is not steady. We do want to change the TAF if the creatinine clearance gets below 60 and if the decline is steady. And then, of course, we have cabotegravir, and if that creatinine clearance gets less than 30, you may indeed be able, a person may use cabotegravir, which again is a nice option. We now recommend that if someone's taking TAF, FTC, Every 12 months, you have the person get on the scale, and you do check a lipid panel because of this weight gain issue. Okay, so cabotegravir, there's a little bit of pattern of follow-up with cabotegravir. So you're going to do one injection, and then 1 month after the first injection, you're going to do another injection. Okay, after that, it's going to be every 2 months. And when you do this cabotegravir injection, the second one, you're going to get, again, the antigen antibody test and the HIV RNA, just like oral PrEP now. Every 2 months, again, HIV testing. And you're going to talk about condoms, limiting partners, access to clean needle syringes, and drug treatment services. And this probably would be at the 1 month visit as well. So every 4 months, it's recommended you screen for STIs in men of sex as men and transgender women. And you also, every 6 months, you're going to do the screening for heterosexually active women and men. Again, a little bit longer space for heterosexuals, but you do have to take into account their sexual activity before each visit. Every 12 months after cabotegravir, I usually assess the desire to continue injections for PrEP and chlamydia screening for heterosexually active women and men. When someone stops cabotegravir, there is an issue because of this long half-life and what we call the tail. And there is risk of getting resistance during this declining cabotegravir level. So it's a very important time not to put yourself at risk for HIV. You may even prescribe oral TDF or FTC, basically beginning with 8 weeks after the last injection, so they don't have this tail effect. And you also want to continue follow-up visits with HIV testing quarterly for 12 months after stopping cabotegravir. Okay, so I'm going to talk just a little bit about same-day PrEP. Many people have been doing it, but it is now formalized in the guidelines, and there are some ideas. Basically, it's kind of on the fact that most people are not going to have HIV when you're talking to them, and most people are going to have a good creatinine clearance. Their kidney function is fine. So you can do point-of-care HIV blood tests, and what you would do is that we would like to have the HIV RNA. If you can't get that, you could do the HIV antigen antibody finger stick, again, a 4th generation, and no oral HIV testing. We do not recommend this for same-day PrEP. There's only one exception to this rule. Point-of-care pregnancy testing for a female, and you draw blood for creatinine and laboratory HIV testing. And what you do is you start the PrEP, but then if there's anything abnormal in the creatinine or the HIV testing when it goes to the lab, we contact the patient immediately. And of course, you do the typical things, assisting patients with enrolling in health insurance, co-payments, and medicine assistance programs. We don't recommend same-day PrEP for many people, basically people that aren't sure they want to do PrEP, and also if they can't get blood drawn for laboratory testing. If they have signs and symptoms and sexual history indicating possible acute HIV, and if they have factors that may imply that they may have renal impairment. And again, hypertension, diabetes are things that you think of. And if someone doesn't have insurance or means to pay, they're not really appropriate for same-day PrEP. We got to work on that a little bit more. And they need to have confirmed means of contact. So if someone does not have a confirmed means of contact, same-day PrEP is definitely not for them. There are other groups that same-day PrEP may not be appropriate for, may very recent possible HIV exposure, may not be easy to contact. And if you have mental health conditions, they can make you issues with adherence a little bit difficult. So we think these groups are not really indicated for same-day PrEP. There's also telehealth, which I'm sure many of you in this conference are very sick of with COVID, or at least I am. But anyways, we've been using a lot of telehealth, and now it's formalized, and certainly, as many of you probably have done, you can use PrEP screening, initiation, follow-up visits, do that by phone or video. You get your home specimens for HIV, STI, and other laboratory tests by home specimen collection kits, or someone could go to the lab and just not visit you. This is the one exception where they do take an oral swab. If someone cannot get to the lab and for HIV testing, they could use this oral swab and photograph the test result, and then you prescribe a 90-day supply of PrEP. Another thing that the guidelines have finally put in and people have been doing for a while, it's 2-1-1 PrEP, or non-daily, event-driven, on-demand PrEP. And this is basically for someone who can plan their sexual encounters and doesn't have them very frequently and doesn't necessarily want to take a pill every day. Basically what it is a person takes 2 pills before sex, 2 to 24 hours, 1 pill 24 hours after the first 2, and then 1 pill 24 hours as a 3rd pill. Not quite as efficacious, but it certainly is protective, and there's good data to suggest that it's a possible option. On demand, though, is only for men who have sex with men, and it's only for TDF, okay, not for TAF. And it's not FDA approved, but again, it is in the guidelines now. You wouldn't want to do on-demand PrEP. Again, kind of the same thing for same-day PrEP. If someone has difficulty adhering to complex dosing regimens, not great for adolescents, people with active substance use disorders, and I add to that mental illness. And then it's also a problem when people have hepatitis B, because basically hepatitis B can cause episodic, if you treat for hepatitis B, which you do with the HIV medicine or the PrEP medicines, the tenofovir is actually hepatitis B medicine. Then when you stop the hepatitis B medicine, you may get a hepatitis flare. And so you want to be concerned about if someone's active hepatitis B, you indeed do not want to do 2-1-1 PrEP. Okay, so future directions of PrEP. And this is kind of different strokes for different folks. And that's kind of the new thought process right now, is we want to have options for a lot of people and they can choose. And that way people are more prone to take PrEP. The first one is islatravir. It's actually a nucleoside reverse transcriptase translocation inhibitor. And it's something that we're working on for HIV treatment as well. For PrEP, it's actually can be given every 28 days, which is really great. The spacing interval is wonderful for people. However, there's a little bit a kink in the wheel right now. The phase 3 studies are on hold due to lymphocytopenia, which is not really significant in someone who doesn't have HIV. It is significant for someone who does have HIV because the lymphocytes are where your CD4 cells are part of, and that's actually the cell that is attacked by HIV. So that could be a concern for treatment, hopefully not a concern for prevention, but again, phase 3 studies are on hold. And islatravir, even the better option for islatravir, in my view, is actually they're now trying to combine it with a hormonal contraceptive and put it in an implant, or just islatravir alone as an implant. Unfortunately, these studies are on hold too due to the unexplained lymphocytopenia. Hopefully, we can get these studies back in action. There's also a dapivirine ring, and people had a lot of hope for that. It is approved by the World Health Organization. It's not approved by the FDA because the protectivity was only 27%. So I think we need to do better with a vaginal ring, but certainly a vaginal ring is a good option. TDF topical, that's also been looked at. And it looks like that works for about 56 days. This is still an experimental phase, but TDF topical may be an option. And then there's another HIV drug, lenacapavir. It's an inhibitor of HIV-1 capsid protein. And this we could give every 6 months, which again would be great. This has been put on hold. There's some issues due to biocompatibility. which basically means that the containers they use to keep people safe that are compounding the drugs, it's not really compatible with lenacapavir, so they have to work on some of those issues. Ropilvirine, the drug that actually is combined with cabotegravir for treatment, is now being looked at oral, injectable, and implant in phase 3 studies for PrEP. So a lot of options out there. Okay, I have one more case study here. I have Brian. He's a 30-year-old cisgender man with no medical problems, and he presents to the Men's Vitality Center asking about PrEP. He's only sexually active when he meets some of his friends on scheduled weekends, since he's very busy with work. He had chlamydia 4 months prior to the visit. His social history is he's sexually active with men and women, 4 partners in the past year, unknown HIV status of the partners, uses condoms a little more than half the time he estimates, doesn't smoke, drinks alcohol occasionally, and doesn't use any illegal drugs. So what would you recommend for Brian? Cabotegravir every 2 months, daily TGF, on-demand TGF FTC, daily TAF FTC. Okay, we have a lot of options. Yeah, I think I'd probably agree with the on-demand TGF FTC. This person doesn't really sound like he's too interested in taking a pill every day, but certainly taking a pill every day is an option if you can convince him that that's the way to go. Also, daily TAF FTC, I probably wouldn't recommend that. This guy is a healthy guy, okay? He's young, he's healthy, has no problems, and I really don't see the need to give TAF. And again, there are issues with TAF with weight gain, so I would probably not choose TAF FTC. Cabotegravir every 2 months could be an option, but again, I'm not totally convinced this guy wants to be on a drug. And basically, if you're taking cabotegravir every 2 months, you are on the drug for 2 months. And the problem with that is this tail. So if he decides he's going to stop this cabotegravir, you're kind of stuck. So I think you need someone a little bit more committed to be on, quote, a medicine in their body every day. So, okay. So, basically, I am done. I just wanted to, I'd love to answer a few of your questions. And I just want to give you some references. So if you have a doubt about PrEP, please call us. You can contact our office. You can also contact the Pacific AIDS Education Training Center. They have different hotlines. One of them is on PEP and one's on PrEP. There's also additional training and technical assistance noted for PrEP, and there's a lot more information you can gain if you want to have a more in-depth detailed discussion of PrEP. There's also a locator, which can be very helpful if you're not doing PrEP yourself, but you want to refer the patients for PrEP. And so these are my references. And as I said, the biggest reference is these guidelines. Basically, this whole entire thing is on the newly published guidelines. Okay, I have a few other references I've used, particularly related to the data on the weight gain with PrEP, and also the data on the kidney function with PrEP. And test, treat, and PrEP to stop this HIV epidemic, even in the face of COVID. So thank you very much, and I'm ready for the questions.
Thanks, Dr. Fantry. If you could go ahead and stop sharing your screen, I will pull up the questions that we've seen in the chat so that you can read them. And that way everyone can see what our questions are.
So I don't have to repeat them.
You don't have to, but can you see them?
I can see them.
Perfect. That means everyone can see them, so you don't have to read them. But if you want to just go through these and let me know if you have questions about when these came up in the presentation, and I can try to clarify.
Okay, so I'm going to admit my ignorance. What's an SUD?
Substance use disorder.
Oh, okay. So people with injection drug use. Okay, well, there is data on this, and the data looks pretty bad if you look at it in the studies, because a lot of people actually didn't take drug. But the efficacy is thought to be as good as for people who are at risk because of sex. So the efficacy is good. And I think, you know, again, there's issues with pills needed to take more based on gender rather than based on what the risk factor is. Okay, so just curious about the risk for breastfeeding. Well, that actually was what I was trying to get at the slide, the question regarding breastfeeding. So it's Truvada is fine to take if you're, and I should use the generic TDF, FTC. Okay, that is fine for breastfeeding. TAF and FTC is fine, but again, it's not recommended for women. And cabotegravir, again, we don't recommend that in someone who's breastfeeding. But many people actually acquire HIV, or many, I should say, children acquire HIV through the breastfeeding process. So certainly you would want to make sure that the woman who's breastfeeding is protected if she continues to have unprotected sex with a male partner. Okay, 3. In general, does insurance pay for HIV RNA as a screening test? That's a great question. All these recommendations have just come out, and you know, former recommendations were the insurance and should be paying for laboratory testing associated with PrEP. So I'm assuming it will happen. Again, though, these are new recommendations, so I hopefully the payment will catch up. Since PrEP is for prevention of HIV acquisition through sex, can you clarify why it is recommended for people with injection drug use? Well, it actually is recommended for people who inject drugs. And there is some data on injection drug users as well. So and actually the uptake with injection drug users, though, is quite poor. In this country, it's about 4% of injection drug users are on PrEP. So I would recommend it for an injection drug user for sure. How efficacious is the 2-1-1 regimen? Yeah, great question. I don't have the exact figures, but they have looked at it. It's not as efficacious. And there are probably 2 factors in the lack of efficacy or less. Again, it's efficacious. I don't have the data, and I'm sorry I don't have the exact numbers. I think the reason why it's maybe less efficacious is 2 factors. One is I think people may actually not actually be as planned with their sexual encounters, okay? And it's possible the regimen isn't as effective. But again, I don't have the numbers. Any news on if the makers of CAB will provide copay cards or financial assistance similar to Gilead? I'm hoping so. I haven't heard that yet, but I'm hoping so. Can same-day PrEP be provided with rapid antibody tests only, not antibody antigen, as long as serum blood test is sent to the lab for HIV? Yeah, yeah, that's a good question. Ideally, we like you to have that antibody antigen test. I think you would want to evaluate the patient, make sure that they really haven't had frequent encounters. Your risk actually for TDF or TAF, okay, the oral drugs, is not really so severe. So if someone is taking the TDF or the TAF for just a day or 2 and they turned out to have HIV, there's not really much of a downside of that, because as I said, the drug gets out of your body quickly. And there really doesn't seem to be much resistance when people have that happen. So they could still use TDF or TAF for treating HIV. The problem is with cabotegravir. It's more of an issue, but same day PrEP, you're not going to be doing cabotegravir anyways, probably. Do you have to have special training certificate to become a PrEP provider? Oh no, definitely not. That's why we're doing this talk, because we want everyone out there providing PrEP. And in fact, you know, I'm an infectious disease doctor. I'm the least person that should be providing PrEP. It should really be people that are primary care doctors, family practitioners, internists. And we've actually started the county health department is now providing PrEP, which we think is awesome, because the people that actually need PrEP are people that don't go to an infectious disease office. In fact, they may not even go to a primary care office, but they would go to an STI clinic or family planning clinic. What if a patient finishes their 28-day PrEP and is again exposed to HIV within a week? Will the doctor put the patient back on PrEP? Yes, they should go back on PrEP. And then they would restart PrEP again after PrEP. How often can a patient be put back on PrEP? What is the risk and the side effects? Well, yeah, I didn't really talk about PrEP, but they can be put back on it as many times as they need. But we really, you know, if they're taking HIV medicines, most of them in this day and age don't have a lot of risks. The biggest risk we see is actually weight gain, because many of our HIV medicines have that TAF in it. But we don't, and there's probably no resistance, because basically our meds are co-formulated. So basically you stop the med and the meds are out of your body at the same time. However, we don't encourage that. And we really try to counsel these people to get on PrEP instead of repeated PrEP. Okay, are there more questions?
That's all I'm seeing for now, but we do have until 12:10. So if there are additional questions, I want to encourage everyone to use the chat, whether that's a question about something that was discussed, or if you have additional questions about what you've been seeing with injectable PrEP or the updated guidelines or anything at all. We do have a few more minutes here with Dr. Fantry. And Dr. Fantry, if you want to elaborate on anything that you maybe cut down on a little bit, we have some time, so feel free to use this time however you'd like.
Yeah, I think I certainly prefer questions, but I certainly have much more I can say. One thing I'd just like to say is that what I kind of hinted at in some of the slides is we really aren't addressing the PrEP problem with the appropriate population. If you look at, again, injection drug users, only 1 to 4% are on PrEP. If you look at Hispanics, if you look at people from lower socioeconomic classes, African Americans, their rates of PrEP are very low, and they don't have a lot of knowledge of PrEP either. And the providers in their community don't really feel that they can know enough to prescribe PrEP or have the resources to do it. So I want to stress that we really want to get PrEP out to the community. And I love that question. You know, do you need special training? Because it really brings the point. We do not want special training. Come to a conference or read about it, and it's a very, very simple thing to do.
I just dropped a couple more questions in there, and I do want to say that someone had shared a resource for a PrEP certification program, so I will share that in the post event email that goes out. Thank you to Cherie who shared that. And then I think, Dr. Fantry, you can probably see this last question from a public health nurse.
Yes, I can. Oh, that's a good question. And I'm probably not the best. Well, I guess I am probably a good person to answer this. So I came to Tucson in 2016, okay? And the first thing I noticed is that we were giving PrEP in our infectious disease office and not the county health department, STI and family planning clinics. And so I tried to get people to do PrEP at the family health department. And I got, well, family health clinic and the STI clinic. And I got a lot of resistance. And so I pretty much gave up. But people in the community persisted with it, and actually we got a new director of both Pima County Health Department and person involved with actually who would plan PrEP, and they pursued it, and they actually went on, and we are just started PrEP actually in January, and I know we have at least 20 to 30 people. So I think it's persistence. I think you really have to stick with it. You have to really recognize that if someone's actually treating STIs, one of the biggest STIs out there is HIV. So that would be my advice. And I could actually give you a reference too, I guess, in the chat of who you might talk to about that. Okay, another question. Year 1994 had the least number of reported new cases relative to other years between 1982 and 2020. Just curious what might have happened in the year 1994 to observe a decreased trend. So I presume that's new cases of HIV.
Yes.
So yeah. Well, I can tell you what happened in 1994. That's exactly when we got our highly active antiretroviral therapy. So even better than PrEP is treating people. So if you treat someone who has HIV and they have a CD or a viral load less than 200, they don't spread the virus. So that's really the key thing. I mean, the primary aspect of preventing HIV is treating everyone. As you've seen in recent slides, that we're not able to treat everyone. That care cascade, only I think it's 56% of people with HIV are suppressed. If those 56% won't transfer the virus to other people. However, if you look at the people that aren't HIV, they're the ones that we're concerned about, and they're the reason why we offer PrEP. Okay, so correct me if I'm wrong, but I didn't see the Hep A serology on the PrEP screening. Is it necessary? Should unknown immunization status be a barrier to same-day PrEP? So so let me explain that a little bit. So the Hep B is on, and it's actually on my slide where I compare the cabotegravir with what you need for oral daily PrEP, and you do get Hep B testing for same-day PrEP because of that risk of the hepatitis flare. You could also argue you should have it for immunization status. And you could also argue you should have it in these groups anyways, just because of it's recommended that people get vaccinated for hepatitis B. Hepatitis A, it's the same issue, although it's not really needed for either PrEP, but we're dealing with groups who are at high risk for hepatitis A. If you're a man who has sex with man, if you have injection drug use, if you're homeless, if you've been in prison, all these people are at high risk for Hep A. So I'm not really saying it's definitely not wrong to get it, and it may be right to get it, but actually for PrEP, you don't necessarily need that. And should unknown immigration status be a barrier to same-day PrEP? I think I'd be very hesitant to do that. But I think you could use your own judgment. But I think you want to make sure, again, the issue is contact, make sure that they're not going to have to leave the country and you can contact them, or issues like that. What is the source of some of the providers resistant to PrEP? Was there previously worse data that I haven't been updated on? Oh yeah, the data was awful. So basically, I think we're up to about 25% of people with indications for PrEP are on PrEP. So that's better than it was, but it was, you know, when it started, it was very poor uptake. And it's the question, what is the resistance to PrEP? Well, I know at the county health department, the resistance, it was they didn't want to be in the mode of continuity of care. So it does get into the mode where you have to see someone quite a bit. And it certainly is continuity of care if you're prescribing PrEP throughout the duration. Other things, it was a barrier, and I think it's less so now, but some of the insurance issues and ways to get PrEP covered were challenging. And I think one other barrier that I can't really not discuss is people don't take sexual histories very well and very often. And that's a big barrier to PrEP. If you're not asking a sexual history, then you don't know who's at risk. So I think that's a big thing too. And I think it's lack of knowledge and fear with the providers. There was a survey that basically a very small, it was done, hopefully this has changed, but only 76% of primary care providers knew of PrEP. So it's not just the patients at the health departments that don't know about PrEP. Hopefully that's now 100%, but there was a very small percentage of providers. It was like 30% that actually felt comfortable providing PrEP. Okay, so
Number 16 is not a question, but I just wanted to say Dr. Fantry's been talking about our partners at a county health department, and a couple of them are on today's call, and I just want to give a shout out and say thank you for all the great work they've done to implement PrEP. And one of them actually shared the item in number 16, which is just information about VIV's savings program for Apretude. So you can skip that one and go to number 17.
Okay. If a patient has Hep B immunization on file, do we still order Hep B labs for PrEP? No. No, you probably don't need that. I guess I'm assuming though, before they got the Hep B immunization, they had labs. I mean, it'd be nice to make sure you didn't immunize someone that already had hepatitis B, chronic active hepatitis B. So I guess I'm assuming with that question that you have Hep status prior to getting the immunization. If there's no immunization, I guess someone could have Hep B immunization, but prior to that had Hep B, and the immunization really wouldn't prevent that, and it wouldn't prevent the flares.
That is our last question for now. So unless there are any final questions or thoughts, I think we can break about 6 minutes early for our lunch break here. Dr. Fantry, did you want to add anything else, or does anybody else have any final questions for her?
Looks like one final question.
I'm just seeing the applause emoji, so I will take that to say, oh wait, actually, nope, we did have one more question. Could a patient on PrEP be put on PEP after a documented exposure?
Well, so again, first thing, if there's a documented exposure, you would do the PEP, and then they can be put on PrEP. In fact, it's a good transitioning, okay, PEP to PrEP. So that actually is definitely recommended. I want to say one more thing. Thank you for all your fantastic questions. They're really great. I appreciate your questions, and thank you for listening.
Thank you so much, Dr. Fantry. Just like with our previous presenters, if anyone would like to be connected to Dr. Fantry, you can email me. We do love hearing from you and enjoy receiving your questions. So whether that's a week from now or 6 months from now, reach out if anything comes up. And with that, we will go to our lunch break, and we would like you all to come back at 12:40. And so you're welcome to do whatever you need to do, and we will see you back at 12:40. Thank you so much, Dr. Fantry. We really appreciate your time and expertise.
Thanks, Brett. Bye-bye.
Hello, everyone. It's 12:40. So just to keep us moving and on schedule, we're going to go ahead and resume presentations. And if you have had a chance to check the agenda, you'll see that we will now be moving into the TB portion of today's training. And so we will start with Evan Tim, who, just like in the previous two sessions, will be giving us a surveillance overview. And so we'll give everybody a few minutes to come back, but Evan, if you want to pull up your slides, you can have that ready. It looks like we have most folks, or, I think everyone's out there. It's kind of hard to tell. So whenever you are ready, you can go ahead and get started. And I will say that following Evan's presentation, we'll hear from Sherry Stafford, and then we will end the day with a presentation from Dr. David Yost. And so, like all of the previous presentations, we'll do a Q&A at the end. So please feel free to share your questions in the chat, and we will pull those up and go over all of them following Dr. Yost's presentation. So thank you again for hanging in there, and thank you, Evan, for being here. Go ahead and you can start whenever you're ready.
All right, so thank you for, letting or having an opportunity for TB to be a part of a discussion at all in general. So for me, my name is Evan Timmy. I work as a surveillance epi for the Arizona Tuberculosis Control Program. And so I wanted to have a little fun with this presentation, share some insights. This is only bits and pieces of some of the information that we have available at our disposal, but I thought I'd try to tailor a few of these elements to be important to those parties who maybe deal just a little bit with TB or not at all, but some of the other morbidities that are included in this session or in the entire day. So what I have displayed right now, Arizona's got a pretty decent history, I think, when it comes to TB being thought of and viewed as a historic or old disease. And so this is one of these sanatoriums. If you're familiar with Tempe Town Lake in Tempe, this was a location of a TB sanatorium just north of Tempe Town Lake near Mill Avenue. And just as in the prior slides that were going during the lunch session, there was a mention about a historic person, so that was Nelson Mandela. I think Arizona often gets maybe framed as TB being old, also with Doc Holliday. So I at least wanted to start with a connection with older TB within Arizona. This is the disclaimer. And then for myself, here's my contact information. And then I do not have any conflicts of interest for this presentation. And I am not providing clinical advice, and everything here is based on surveillance data. So this is not an electronic medical record assessment or any type of patient-involved research. And then points for today, what I want to do is kind of walk you through a little bit about what we see nationally for tuberculosis as like a quick snapshot, what it looks a little bit more like here locally in Arizona. And then lastly, try to pull in some of those comorbidities that are somewhat of an element of interest for tuberculosis. And when I'm referring to tuberculosis, it's active tuberculosis disease. So starting off here, it's classic for national reporting to occur on World TB Day or around World TB Day, which is March 24th. And so over the past decade, we as a nation have seen a continual decrease in the reported number of active tuberculosis patients in a given year. And what we've noticed this year in the orange bar is a slight rebound to case reporting year 2020. The dotted blue line provides an estimated trend of what we would expect to see. And both last year as well as 2020 were below the expected values. There's a lot of theories and insights into why this may be. I think we're still unpackaging it just as like everyone else. But it is, we do see a bit of a return to where we would more likely expect to be on a national level. And this is newly persons diagnosed with active TB. From a geographic perspective, there's a little bit more variance across the US when we look at case counts, and these are overall whole counts of persons per given state. And on an average year, we tend to see about 50% of all active tuberculosis diagnosed in the 4 major states of California, Texas, Florida, and New York. So that holds true and still holds true for the past 2 years. And that tends to be a component. And Arizona lies in like the middle-ish ground. Looking more at a way that helps kind of allows us to assess population differences or in different populations is the incidence rate. So this is for 100,000 persons. And so nationally, we're about 2.4 per 100,000 and maybe expecting to be a little bit higher than that based on past trends. This is where we're at. And one thing I do want to point out, when we talk about definitions, one thing we do mention or use sometimes is the definition of elimination. And so there is actually a numeric component, and that would be one case or one individual diagnosed per 1 million persons in the population. So that's that red dotted line in the bottom that I have the arrow pointing to. That is almost at 0, but is at 1 per 1 million, or in this, it's 0.1 per 100,000 persons. So we're trending in the right direction, but we're not there. And then as an incidence rate across the US, what we're looking at is a little bit more uniformity when we adjust for the population differences across the states. And as state of Arizona, we are within the mix of between 1 and 2 per 100,000. What we'll see here is a dig more into the Arizona side of things. So for case year 2021, we had 129 reported active TB patients. And when we consider comparisons to prior years, it was a 5% decrease from the prior year, but we think it's probably a little bit more helpful to place it in the context of a broader historic range. So we do also provide an assessment that looks back at the prior 5 years and compares the average, and that's a 26% decrease in the number of active patients diagnosed. Making the same adjustments for incidence rate as within Arizona, I mentioned we were between 1 and 2. We're around 1.8 per 100,000 persons, so substantially higher than the elimination goal, which is 0.1 per 100,000. And then comparing to the prior years, also a 5% decrease from the prior year, but we're up a little bit with a greater decline compared to the 5-year average of incidence, which is a 29% decrease. And just as a quick snapshot, county listings on the left-hand column, followed by number of persons diagnosed in case year 2021 as a whole count, and then the population information. What I do want to note here is about half of counties within Arizona did not report an active TB patient within case year 2021. And of those 8 counties that did report, only 4 of them had more than 1 case per 100 or per case for the entire year. And so we can definitely see that there are some counties that are having a higher burden of active TB compared to the rest of the state. And then when we overlay incidents comparing the US, which would be the blue, so we have case counts on the bars, and then the blue line referring to the US incidents. The Arizona incidence has classically been below the national for the incidence rate. And we can see we start to diverge a little bit in this most recent year, where the US saw a slight uptick, and here within Arizona we saw another smaller decrease, which was that of 5% for the prior year. So it would be difficult not to talk about an elephant in the room. So what I want to highlight here is a way of utilizing what systems may be in place. So what I'm displaying here as a visual is laboratory data. So these are the number of unique samples that are submitted to the state laboratory for acid-fast bacilli testing. And the gray/whitish bars are pre-pandemic totals, and it's on a monthly basis. And the peachy color is 2020, and the more acute red is 2021 case reporting. And so starting in April of 2020 is when we noticed a big drop in the number of unique specimens coming into our state lab, and that sustained all the way through the entire year of 2020, and basically continues on to today, that we're at a decline or at a lower level of unique isolates coming into the state lab. This may be one of the contributing factors to decline, but we do not have control over the samples coming in. It's a mixture of hospitals that are reporting their Arizona Administrative Code required submittal of a TB positive isolate, or from some of our county partners that routinely use the state lab. But I think it's interesting to take a look and see, and I saw that Max had reviewed some similar information based on decline in sample testing. And so this is one utility of the information that we have at our disposal. And on to maybe some more interesting things for this group, getting into the comorbidities that we see. So about 3 years ago, we, as a tuberculosis program, partnered with the HIV surveillance program at the State Health Department. We did a 20+ year review of individuals who were identified and matched to have both active tuberculosis at any point in time and also have a positive HIV surveillance record. And the white line indicates that point in time of their HIV diagnosis, and then the red would indicate the proportion of persons, or the whole count of persons that were diagnosed for TB. So that large bar we can see is indicating the proportion of persons who develop TB disease within 1 year after their HIV diagnosis. And so overall, what we're seeing is well north of 90% of individuals who were identified in this had acquired tuberculosis, or had at least a reported tuberculosis laboratory or case that occurred after their known HIV positive status. And so this is where we want to continue to think, these two things from testing perspective on the TB side are important for the individual. And then digging into hepatitis. So there was a change in standards of collection of the type of data that TB patients are having collected on their behalf. And starting in 2020, there was a dedicated either Hep B or Hep C question that was looking to capture, has this individual had a prior diagnosis of either Hep B or Hep C? In the past, we've used or encouraged the free text collection. And so there's a little bit of volatility prior to 2020. But what we're seeing here is that there is some overlap in every year that we know, at least identifying individuals who are either having Hep B or Hep C, in addition to their TB diagnosis. And then lastly, COXI or valley fever. So Arizona is a prominent reporter of valley fever within the US. And so being a pulmonary disease, we also think it's important to kind of look at the cross spectrum picture of both of these diseases within the same person or within the various separate individuals. And I reference this quote because we also had a data change in 2020 where we indicated that there is a specific variable that is explicitly asking if there is a known valley fever diagnosis for this individual or not. And so it started in 2020. We originally did some workup in 2017 to 2018 to better understand what this looks like in Arizona between comorbidity of active tuberculosis and valley fever. And starting in 2019, we provided more guidance in how we wanted to capture that information. And that was the utilization of a free text string of either valley fever or COXI. And so we can see starting from 2019 of when we provided more training and outreach to our local partners that collect the active tuberculosis surveillance information, we were able to get a better assessment. And what we've seen in the past for a cross-matching review is about 1 in 9 individuals who were diagnosed with active TB also having a matched COVID positive prior case. So fairly common compared to some other morbidities that we do see. And that's the point right there where we started making the intervention. And then lastly, feel free to reach out. I think it's helpful to have an open dialogue. And I am very thankful for the partners that we do have, the local health partners that are TB that are related to our program that are near and dear to us. And many of them are on the call today. And I also do want to thank Sherry Stafford, who is our nurse consultant, for pulling me in, asking for some insights. Data can always be a little nerdy and sometimes dirty, but I think when you have good visuals and good sets of eyes to scan and assess presentations, you can make some pretty looking slides for an audience. So I want to pass it off to Sherry going forward. So thank you.
Thank you so much, Evan. I really appreciate the way that you put that all together. I think it makes it a lot easier to digest. So thank you so much. And I also am thankful for Sherry Stafford. So I'm going to pass it off to her, and she's going to share some TB resources.
Yes, so thank you everybody for joining us today and sticking in to talk about TB, the very last topic of the day. Let me go ahead and make this small. Okay, cool. Now it's not on my way anymore. So I'm the nurse coordinator for the state TB program, and I am talking to you from sunny Phoenix, Arizona, where you can use palm trees as bike racks. So I know that we have a lot of people that are not from Arizona, but this is, so we're going to share stuff that is useful for everybody across the country, and then we'll also throw in some stuff that is specific to Arizona as well. So normally, if it was in person, I would be able to hand out stuff to you. But since it's not in person, I want to make sure that you leave this, this day-long presentation with some tools that are useful for you when it comes to TB. So that is really the purpose of the next 10 minutes. But first, I have a question for you guys. Why is TB included in the HIV STI annual update? It used to not be. It used to be just the two diseases, and then we added in TB. So I'll give you a moment to think about it, and then I'll have a couple answers for you. So you might say, well, TB and HIV, there's a synergy there. People living with HIV have a 7 to 10% annual risk of developing TB disease if infected with TB. That's compared with a 10% lifetime risk in immunocompetent adults. So that's a huge risk factor for the HIV infected population. You might also say, well, we can't eliminate TB if it's just the TB programs that are trying to get us down to be that 1 per 1 million, right? We need to have our partners, we need to bring our partners on board. So this is a good opportunity for us to do outreach outside of the TB program. And I know many of you may work in TB, but some of you don't. So I appreciate having this opportunity to talk to you about tuberculosis and to be able to share our tools, and also have somebody like Dr. Yost to be able to go over case studies with you. And then we have many of our healthcare workers that do it all, work in HIV, STIs, and TB. And I know several of you are on this line. And then also, lastly, TB is a really cool disease. So I think everybody likes hearing about it because it is so cool to talk about. So one of the resources that you can find is on CDC's website. And you can find cool posters like this if you want to print some out and hang them up on your clinic. That way you can kind of get people to think about TB. And you can see it has the whole iceberg principle, you know, like with most people having latent TB and very few people on an annual basis having TB disease. Even better, hang on just one second, okay. Even better, there's this poster. I really like this. This is a really good teaching tool, not only for staff, but for patients if they were to be tested and found to have latent TB infection. Because you could go through the TB life cycle and talk to them about how TB is an airborne disease and how it can spread from one person to the other. You breathe it in, it goes to your lungs, your immune system's working, and it's able to wall off the TB, and you're not currently sick, but you still have the germ in your body, and that's what latent TB is. You can stop TB by taking medication, and that is treatment for latent TB. And but there are some people that end up developing TB disease. Maybe they didn't have a strong immune system like people with HIV, and they end up being sick with the germ's causing damage to their body, but they also can break the cycle by taking medications. And those medications can cure them and also prevent their family from becoming sick from them being around them. Here are some other really useful patient education materials. What I like to do is I actually print this out front and back in English and Spanish, because Spanish is a common language here in Arizona. Not a big surprise since we're a border state. And this is a useful patient education tool. There's also videos that are available, and there are multiple other languages for this same thing that you can print out for your patients if you want to use as an education tool. Another useful patient education tool is this website, where you can put in the different risk factors that your patient has and then print out results. And this is a nice way to kind of present it to your patient. What is their risk of developing TB disease later on? And it's personalized, which is nice for a patient to see. So I put in a fake patient having a positive QFT. He's 36, born in Mexico, immigrated at age 25. He was vaccinated, no known contact, but there is an abnormal chest x-ray and they're HIV positive. It is most likely to be positive. That is a true positive test. And they have an 8% chance annual risk of developing TB disease. And they say it's 100% up to age 80, but I don't believe in 100%. But there's a very high risk of them developing TB disease. And so this can be personalized for your patients. And then there's some resources as well for healthcare providers. I really like these, and I am going to show you this one really quick. So let me go ahead and pull it up. It is right here. So it's a nice cascade of care. You can order it or you can print it out. I do like the physical product better because it folds up really nicely. There's also other resources. So let me go ahead and continue there. Oops. Onto the right place. There we go. Okay, so here is this booklet from CDC, which those of you in TB have probably seen that. I highly recommend it. It's user-friendly. And then for HIV, there is a pocket guide, which I'm going to show you as well. And this is super useful for HIV providers. Again, it's really dense information, but it's a useful pocket that you can either print out or you can order. And there's more full guidelines available online. There is a slight discordance on, this is from August 2021, and this is from February 17th, 2022. So there's a slight difference. There's some minor differences that you can see on this if you go to this guideline. So if I show it to you here really quick, this is the pocket guideline. Again, you can see it's really dense. And then if you go to this, here are the guidelines, lots of details. So let me go ahead and go back to this. But your best resource is knowing who your human resource is. Who is your TB expert? So in Arizona, if you don't know who your local TB expert is, go ahead and contact me and I'll get you in touch with them. In Arizona, our Center of Excellence has a warm line, and that's Curry Center. There's information on your packet that how to contact them if you wanted to discuss an interesting, a difficult case with them. And one of the human resources is going to be talking next, and that's Dr. Yost. This is our website for the state of Arizona. On that website, I hope to have some FAQs on TB screening of healthcare personnel in Arizona in May, hopefully, fingers crossed. And not so breaking news, just to make sure everybody knows that the COVID vaccine and TB tests do not need to be spaced over time. I think everybody knows that now, but just in case you don't, I added this in. So before I move on, if you do have any recommended TB resources, add it to the chat. Or if you're looking for a TB resource, put it in the chat and we can discuss in the Q&A session at the end of these case studies. And I am going to hand it over to Dr. Yost. But first, let me go ahead and stop sharing. And I am going to do a quick introduction for him. And while I'm getting everything up, if everybody can go ahead and take a quick stretch break, roll your neck a little bit because we're getting to the very last of a long day. And I do have it here. Okay, so Dr. Yost, he has spent more than 3 decades providing primary care, public health, and infectious disease expertise to communities throughout North America, the Caribbean, and the South Pacific. Through clinical and leadership assignments with the Indian Health Service and the Centers for Disease Control's Division of Tuberculosis Elimination, Dr. Yost has focused on health disparities and outbreak control efforts in Indigenous populations. Balancing the joys of semi-retirement with an ongoing passion to work with underserved people, Dr. Yost currently divides his time between grandparenting in Indiana, fishing the streams and lakes of Arizona's White Mountains, and training new Indian Health Service clinicians, and serving as medical director of the Pima County Tuberculosis Program in Southern Arizona. And I can say that I'm very happy that he is spending his retirement working in TB. And without further ado, I'm going to pass it over to him and let me stop. I stopped sharing, so you should be able to share.
Okay. Thanks a lot. And again, I appreciate the introduction and the opportunity to share some things with you. Being the end of the day, we're going to try to keep this a little lighter. I'm also going to keep this a little bit more on a basic level to start with. I realize that many of the people on this call, TB is just one of those little added other duties as assigned. As Evan clearly showed, we're one of those diseases in decline. So quite a few people don't deal with TB on a regular basis. And I do want to make sure that we all can speak a common language. Next slide. So it's our standard disclaimer. And I want to start here with a text. So as Sherry mentioned, I am a primary care clinician at heart, a family practitioner by training. I spent most of my career up in the mountains with the Indian Health Service. And this is a text I received a while back. I also serve as the Indian Health Service consultant for TB. So I was running on my way to the delivery room, a lady in active labor, and as I often do, I threw my cell phone at the clerk at the desk and said, hey, if there's any emergencies, just come wave at the door and let me know what's going on. The first thing for everybody to know is there are very few TB emergencies. That's one nice thing about TB. So as I was attending to the lady in delivery, I looked up and there was the clerk with a very confused look on her face, holding up my cell phone. And she says, you got a message? And I said, is it an emergent? And she said, I don't know. There's no words on it. She says, it's all letters and numbers. And I said, well, I'll tell you what, why don't you go ahead and respond back to the person and ask them to clarify what's going on. And next slide. This is what she replied back. She says, please clarify everything. And as you see, there are a lot of acronyms there, a lot of strange things. And we're going to be able to read through this by the end of this presentation and make some sense of it. Next slide. So our objectives today is to be able to describe some common methods for diagnosing and treating LTBI that can lead to improved treatment and outcomes for patients. And we're going to identify groups who are at risk for TB and should undergo screening to prevent TB disease. And we're going to become a little knowledgeable in all those TB-related acronyms. TB people are notorious for speaking in strange languages, but we want you to be comfortable and versatile in those. Next slide. Again, my own conflict of interest, I have none. I've worked for a whole lot of agencies from the CDC to the IHS to the Pima County. and I'm not speaking officially for any of them. Next slide. So let's start with some basic definitions. LTBI, latent tuberculosis infection. The World Health Organization says this is a state of persistent immune response to stimulation by Mycobacterium tuberculosis antigens without evidence of clinically manifested active TB. All right, that's a long way of saying what the CDC says a little more clearly, which is that people with LTBI do not have signs and symptoms of TB disease. We abbreviate that TBD, and they cannot spread Mycobacterium tuberculosis to other people. Next slide. Which leads us to this very, very common chart. Now, in TB world, we now appreciate that TB is really a spectrum, but in most cases, it's easiest to divide it up into these two ends of the spectrum. And Sherry showed a version of this chart. You can find a million different type of representations of this, but it comes down to this. On the left side of the spectrum is latent tuberculosis infection, or LTBI. In this case, you have no symptoms or physical findings suggestive of TB disease. Your blood test or your skin test is usually positive, but your chest x-ray is typically normal. And if you get sputum and you send it for smears or cultures, those are going to come back negative. You cannot spread TB bacteria to other people. This is not the infectious form of TB. But you should consider treatment for LTBI patients to prevent them from having TB disease. And that's the right-hand side, or the right column of this spectrum. With TB disease, you now have symptoms, often fever, cough, chest pain, hemoptysis. Your TB blood test, or your TST, which is your tuberculosis skin test, will be positive. But your chest x-ray is also usually abnormal. In some people with advanced immunosuppression, it can be normal, but for the most part, you have an abnormal chest x-ray. Respiratory specimens are usually positive, occasionally not if you have extrapulmonary TB. But most importantly, you can spread TB to other people, and you need to be treated for TB disease. Next slide. So my wife's a kindergarten teacher. I live in the mountains, which is bear country, and she said, here's an easier way to put it, and she's right. So latent tuberculosis infection is this nice sleeping, hibernating bear, okay? Non-infectious, not causing a problem. But tuberculosis disease is that bear that you encounter on the trail when you get between her and her cubs, and that's a problem and can be a problem for everybody around you. Next slide. So why do we even care about LTBI if it's not a problem? Well, WHO estimates that about 2.5 billion people in the world, or about 1/3 of the world's population, are infected with TB. The CDC says in the United States, about 13 million people living in our country have latent tuberculosis infection, or LTBI. Now, this is the important part. In our country, in the United States, 80% of the TB disease, the active cases that we see, come from people who had long-standing untreated latent tuberculosis infection and subsequently activated to TB disease. Now, Sherry said 5 to 10% of infected people who do not receive treatment for latent TB will eventually develop TB disease at some time in their lives. That's why we're focused on this issue. Next slide. So who's at risk for getting infected with TB? Well, the people who have recently been exposed. So close contacts of a person with infectious TB disease. Immigrants from countries with high rates of TB. Children less than 5 who have a positive TB test that indicates that they've been exposed relatively recently. Groups with high rates of TB transmission, like people in homeless situations, IV drug users, HIV positive people, and people who work or reside in high-risk TB settings, such as hospitals, homeless shelters, prisons, and nursing homes. Again, realizing that not all healthcare facilities are high-risk TB environments, but many of them are. Next slide. Now, what about those people who progress from LTBI to TB disease? We know that there's certain categories that are at very high risk for this progression. In particular, people with conditions that have weakened immune systems, things such as HIV infection, substance abuse, diabetes, severe kidney disease, people who are very malnourished with low body weights, people who have organ transplants, head and neck cancer, or people who are taking medications that suppress their immune system, such as corticosteroids or transplant rejection medications, or some of the medications we use for rheumatologic conditions or things like Crohn's disease. Next slide. All right, so who do we get out and actually test? Who are we looking for? Well, we want to test those people who have spent time with somebody who has TB disease. We want to test people who come to the United States from countries where TB is very common. That includes most countries in Africa and Asia, many Latin American countries, Eastern Europe countries. We want to look at people who live or work in high-risk settings, like correctional facilities, long-term care facilities, nursing homes, homeless shelters. These can be the target people that we want to test. Next slide. Additionally, we want to look at healthcare workers, people who care for patients that are at increased risk for TB disease. And we want to look at infants and children and adolescents who are exposed to adults who are at high risk for TB. Next slide. So how do we test? Now, again, this seems like basics for people, but it's good that we all have the same type of information. So we have two ways to test. One way is through what we call the IGRAs, or the interferon gamma release assay. Those are the blood tests. We have two kinds of blood tests available to us in the United States. That's the T-spot, and then the quantiferon TB Gold Plus, or the QFT. Okay, those are single draw blood tests. You only have to see a patient once, you draw their blood, and in a few days you get your answer back. Now, it's important to note that this is not an absolute gold standard. We do not have an absolute gold standard for diagnosing TB. There can be false positives, there can be false negatives, even with the IGRA blood tests. Then there's the long-standing way that most of us are very familiar with, the tuberculin skin test. Now, we sometimes interchange TST and PPD. PPD is actually the abbreviation for the material we use to administer the test, but it really means the same thing to us if you had a PPD test or you had a TST test. Now, this is a very important thing to note with this, that we realized over the years that the results from the skin test depend on what type of person you are. And we call your skin test positive depending on what your own background is. So for example, if you have an induration, that's the palpable swelling, of 5 millimeters, you would be considered positive if you're immunosuppressed, such as being HIV positive or being an organ transplant recipient, or if you've had very recent contact with an active TB patient, or if you have changes on any chest x-rays. However, you need to be 10 millimeters to be positive if you're a young child, if you're a high-risk healthcare worker, or if you have comorbidities such as renal disease or diabetes, or an IV drug user. Most importantly, we don't consider you positive if you're an absolutely healthy person with no known risk factors until you have a skin reaction of at least 15 millimeters. So when somebody says I have a positive skin test, the very first thing to do is ask them, what are the details of that? And we'll come back to this in one of our case studies. Next slide. Okay, so we're in the business of testing. Many of you work in health departments and you're being asked to test people. Here's our question number one. So your PPD supplies fell off the delivery van and your budget's nearly shot. You have money to do just 2 quantiferon tests that are left. Okay, that's all you can afford. It's near the end of your fiscal year. But you have 3 patients in the clinic who are demanding testing. Your question is, which one of these 3 gets sent home and asked to come back for a later test? So here's your 3 patients. You have a 34-year-old HIV positive patient who has recently spent time in a homeless shelter in Los Angeles. You have a 45-year-old locums CRNA, a nurse anesthetist, who recently came back after a 3-month volunteer mission. The person was providing respiratory services in the slums of Calcutta in India. And then there's your 64-year-old CEO who knocks on your door and says, hey, my travel agent says I might need a baseline TB test for my upcoming glamping safari in South Africa. All right, we'll give you a few minutes. Again, we're end of the day, so we decided not to make these questions too hard. And our results, most of you said, yes, it's the CEO. All of these people may have an indication. Some people would say, well, wait, your CEO is going to South Africa. Isn't that one of the highest TB places in the world? Well, yes, it actually is, but the person hasn't been exposed yet. So if you only had a couple people to test, I would definitely focus on your immunosuppressed patient who's been in a homeless shelter in Los Angeles. Los Angeles County has some of the highest TB rates in the United States. And certainly your person who was working in India, which is one of our highest TB countries in the world. So next slide. And yes, here's our answer. All right, so you've decided you've got a positive test. What are you going to do next? Is a positive blood test or a skin test alone all it takes for a diagnosis of LTBI? Well, no, there's a bit more than that. As we said, you need to get some history, and there's a physical that goes with this. Does the person have any symptoms of active TB? Do they have any physical findings? Are they sitting in front of you coughing? Is there hemoptysis? Do you glance down at their chart and see that they've lost 20 pounds in the last 4 months? These are all important physical findings. And then there's the issue of a chest x-ray. As we said, people with LTBI should have a normal chest x-ray with no signs of active TB. Now, in most circumstances, you're also going to consider some laboratory tests. And these are primarily to assist you in determining what type of treatment might be appropriate. Not everybody will get laboratory tests with this, but in most of our institutions, we'll make sure we know what their baseline liver function is. We want to know what their status is in terms of diabetes, and their HIV status. Next slide. All right, we use a lot of abbreviations. Here's one we use all the time, 3HP. So I'm going to give you some choices here. 3HP stands for an architectural firm in Singapore, or B, a dockside cafe in Taiwan catering to rowdy fishermen. C, a Facebook gaming channel that your boss is likely going to block if he peeks over and sees it on your computer. Or D, the go-to short course for LTBI treatment. Our results. A couple of you were brave enough, because you know what? This is the end of the day question. Next slide. All of these are correct. This is an Oprah question. Everybody gets a car. But clearly, we are looking for the last one, which is that 3HP is our go-to short course LTBI drug regimen. But if you happen to be needing an architect in Singapore, looking for a place to eat in Taiwan, or really want to risk getting your computer shut off, all of the other three are correct answers for 3HP as well. So where does the term 3HP come from? This is just common lingo in every TB program, so we should know a little bit about it. So the 3HP abbreviation comes from the following. It's a regimen duration of once weekly doses of medication for 3 months, and it's from the abbreviation of each of the 2 drugs used. Now, we abbreviate isoniazid as INH, and so we plucked the H out of INH, and we plucked the P out of RPT, which is the abbreviation for rifapentine. Now, this is also known as the 12-week regimen. People who are good counters know that all months don't have the same number of days, so it is actually 12 weeks, but we chose 3HP, and that's what we call it. Next slide. Okay, if there's a cornerstone slide to this presentation, this is it. And I will tell everybody right offhand that this is on the CDC website. All you have to do is Google CDC LTBI treatment guidelines, and you will find yourself at the site looking at this. And this is what we're going to focus on for a few minutes. So we've talked about 3HP a little bit, and we're going to talk about it in more detail. 3HP is one of the preferred options. You'll notice on the green bars on the left-hand side, we've divided these 4 treatment regimens into preferred options and alternatives. So up at the top, we have isoniazid and rifapentine. This is a 3-month course. You take it once a week. The standard dose for an adult is 900 milligrams of rifapentine, 900 milligrams of isoniazid once a week. There are weight adjustments for smaller adults, and this can be adjusted all the way down to 2 years of age. Now, you can also go with a treatment course of rifampin alone. Now, that would be a daily course once a day for 4 months, 120 total doses. This can be used for children, and it can be used down to less than 2 years of age. We can also use isoniazid and rifampin in combination for 3 months on a daily basis, and that's 90 doses, and again, can be weight adjusted for adults and children. One thing to know about rifampin and isoniazid is there are liquid formulations of both. However, I do not believe there's a liquid formulation of rifapentine. That's just one of a number of reasons we do not use it for children under 2. The alternative regimens are ones that we use for many, many, many years, which are very long course regimens of daily isoniazid, sometimes administered twice weekly, but really are really daily regimens when we consider using these. That's a long time to take a medication. People get bored. People tend to abandon these regimens, and they have a fair amount of toxicity. Isoniazid is one of our most liver toxic drugs that we use, and so there are definitely some disadvantages to this. Next slide. So with our treatment options, short course treatment regimens like 3HP and 4R, now again, 4R is the 4 months of daily rifampin. These short course regimens are effective, safe, and have higher completion rates than the longer 6 to 9 months of isoniazid monotherapy. And those regimens we abbreviate as 6H or 9H. The shorter rifamycin-based treatment regimens generally have a lower risk of hepatotoxicity than the 6H and 9H options. Next slide. So a couple tips on this. 3HP is appropriate in persons with LTBI ages 2 to 17. And it can be used in persons with LTBI who have HIV infection, including AIDS, and are taking antiretroviral medications with acceptable drug-drug interactions with rifapentine. Now, this is a huge caveat. The rifamycins, rifapentine and rifampin, all have a substantial number of drug-drug interactions. And there are certain HIV antiretroviral medications that they do not pair well with. And this is a complex issue. But there are other combinations they do work well with. So we do say you can use it in some HIV patients taking antiretrovirals, but you need to be selective. The other important thing to note is that you can use 3HP by direct observed therapy, that's DOT, or self-administered therapy, that's SAT, in persons greater than 2 years old, okay? Now, these are all changes from the very original released recommendation of 3HP. When 3HP first came out, we said it was for adults only, that you could never use it with HIV infections, and it always had to be by DOT. But since those first guidelines came out in 2011, CDC has made a number of revisions. Next slide. And you can find these on the CDC website, where they will go through these in detail. But again, it can be done as self-administered therapy. It can be used in young children, and it can be used in people living with HIV/AIDS. Next slide. All right, let's talk about a couple of scenarios that come up quite commonly when you're out in the field and you're actually trying to administer 3HP with somebody. So the first issue is missed doses. So what do you do with a regimen where you've just got 12 doses that you're doing once a week for 12 weeks? So if your patient calls and says, oh, I forgot, I know I'm supposed to take it every Monday night, but here we are Wednesday, what do I do? The answer is go ahead and give the dose on Wednesday and then resume your regularly scheduled dosing on Monday if that was your scheduled day, okay? The second one is one we don't usually tell patients right up front, but it's important for us to know as health professionals, which is, in reality, we say you have 16 weeks to get those 12 weekly doses in. So if a patient misses a week, we say, okay, we missed a week, but we're going to go ahead and resume, and we're going to go back to our scheduled week. And you can tolerate missing a week here or a week there. The limits to that is we don't want to see a gap of greater than 4 weeks between doses during the treatment course. Once that happens, we go back to 0 and we start all over again. And again, we usually don't start out by telling patients, hey, don't worry, you can forget doses here or there. We're actually pretty strict about it. Now, we did discuss a little bit about the difference between direct observed therapy and self-administered therapy. The studies that support using it in self-administered therapy do say in patients that you have confidence in that they will remember to take their doses. We certainly in some programs still use direct observed therapy, oftentimes through a video program, if there's any thought that this person needs more support in completing their 3HP course. Next slide. All right, some special scenarios. So as we talked about the rifamycins, and that includes the rifapentine that we use with 3HP, they're notorious for some drug interactions. And I put a few of them on here. There's one more I'll mention. One is methadone and chronic narcotics. So rifapentine, again, that's the RPT abbreviation, it can decrease opiate levels and potentially precipitate withdrawal. So if you've got a person who's on chronic narcotics, that can be an issue. The same with Coumadin or warfarin, that rifapentine can decrease warfarin levels. And so you can have a person, maybe they have an artificial heart valve and they've had a very stable target INR for years, but you might have to make some dosage adjustments. So you need to be sure that you work cooperatively with whoever's prescribing their warfarin. And again, with antiretrovirals, some, but not all antiretroviral medications may be incompatible with rifapentine, and you need to check. The one I didn't put on here is oral contraceptives. So rifapentine and rifampin both can decrease the efficacy of oral contraceptives. And that does actually also include implantable hormonal contraceptives such as Nexplanon. That there is a higher incidence of unintended pregnancy in women who are using oral contraceptives and hormonal contraceptives when they're placed on rifampin or rifapentine. That's something to counsel people about in using an alternative contraceptive method. Next slide. All right, we're going to end with a couple of case studies here. And these are all based on things that I've run into. We've changed just enough to not make them uniquely identifiable. So here's our first patient. Many of your health programs do deal with immigrants. As we talked about before, more than half of the active TB cases in the United States do appear in immigrants who have recently moved in. So in this case, it's a 30-year-old Tanzanian female. She happens to be HIV positive. And as part of her immigration screening process, she was found to have a positive quantiferon. That's one of the IGRA tests. She's completely asymptomatic and she has a normal chest x-ray, a normal A1C, normal liver functions. As part of the immigration process, she also ended up getting sputum smears and cultures, a set of 3, and those were all negative. When we talked to her, she said, yeah, my uncle who lived in our house, and it was a house with a lot of folks, did die of TB about 8 years ago. And she says, and I heard about other people in my community that had TB, but I don't know of anybody else other than my uncle. Next slide. Okay, so here's your poll choices here. Your first choice is no further workup. I know what I need to know. I'm going to go ahead and treat her right now with 3-HP. Your next one is, well, there's no further workup, but I'm going to give her 9 months of isoniazid instead right now. Your third choice is, I'm going to contact the HIV provider to establish an LTBI regimen consistent with her HIV medications. And your fourth choice is, I'm not going to treat her for LTBI at all. That exposure was more than 5 years ago, and she's looking pretty good right now with no signs of TB. She does not need LTBI treatment. Okay. Let's see what results we have. Good. Okay. I would argue that, next slide. There you go. I would argue that number C, or letter C, would be your best choice. And again, the issue being, depending on what type of HIV regimen she was on, and some of you are saying, well, wait, you didn't say she was being treated for HIV. Okay, I'll grant you that. But let's assume she's being treated for HIV. It is very important to know what type of antiretroviral she's being treated with, because again, some regimens are consistent and can be used with 3-HP, some cannot be, okay? I would not start her on 3-HP blindly, because you could really mess up her HIV care. I would certainly treat her, so I don't think D is an option here. Again, HIV patients are at extraordinarily high risk to convert their LTBI to active disease. And the fact that her one known exposure was 8 years ago does not change my mind on that. Now, there's a small argument for B. You could say, well, I don't know if I'm going to see this person again. I don't know who she's going to see. Now's my point in time, and I know I can use isoniazid, so I'll go ahead and do that. Again, the reason I shy away from that is we know there's just an enormously higher chance that she's going to complete her regimen if we can put her on a 12-week regimen rather than a 9-month regimen at all. Okay, let's go ahead and go to the next slide. Here's our case study number 2. All right, this was an exact one I faced not too long ago here. So 50-year-old male new hire housekeeper from a local drug treatment facility down the road. And he's sent over to your public health department, and somebody has scrawled a referral note just on the back of a flyer is how it came over. And this is exactly what it said. Positive TB test. Please start on TB treatment so he can work this weekend. That was the extent of the referral. We went to the file and said, wow, we haven't seen this person for 10 years ago, but there's an indication that he had a chart from about 10 years ago. But as luck has it, it was archived and that chart was not immediately accessible. Okay, next slide. All right, this is not one I'm going to have you vote on, but I want you to think about, okay? So as luck often is in these cases, it's an end of the day thing. You don't have a ton of time. You'd like to find out a whole lot more, but which of these type of things, if you had to rank in order, which one of these things should you really be asking? Which are important, which are not important? Does he have insurance to cover the TB treatment? Does he have a history of TB exposure? What other comorbidities does he have? What about his HIV status, his diabetes status, his liver function, his chest x-rays? Does he have TB symptoms? And then lastly, exactly what type of TB test did he have? What were the results? Next slide. So this is how I would rank these, and I will grant that maybe there should be an inverse in these top two. As I mentioned before, when somebody hands you a note and says, I have a positive TB test, I have to stop right there and say, what did you actually have? If it was a skin test, we need to know a lot more about you and figure out who called it positive and for what reason. We didn't talk too much in detail about skin tests, and I think most of you know that redness alone does not constitute a positive skin test. We're looking for induration. So how that was read and determined if it was a skin test is an issue. If it was a blood test, we'd like to know the details about that too. Now, The issue of do you have TB symptoms? I will accept that argument. Maybe that's number one, because if the person walks into you and has a handkerchief full of blood that he's coughing up, that's probably your most important thing to know, so you can put a mask on him and get him isolated right away. What about other comorbidities? Yeah, we need to know about that. We need to know about his HIV, his diabetes, his chest x-ray. We want to know if he's ever been exposed to TB. We should not be worried as a public health system whether he has insurance to cover TB treatment. TB treatment is available to people in his situation. Next slide. All right, now we're going to get to the polling on this, but let's go over what we found out. So we asked this guy a few more questions. And then what we ended up saying is that he had no further TB symptoms. His TB test was a skin test, but it was 20 millimeters. The same he had 10 years ago when his family was tested after their grandmother's death from TB. So that skin test was actually done by your own health department. You just couldn't see it because it was 10 years ago and they stuffed the chart away in some warehouse. He was recommended for TB treatment back then, but he never had it. He is diabetic, but he's HIV negative. However, he's had multiple admissions for cirrhosis and alcoholic hepatitis, and his baseline LFTs are elevated. His chest x-ray is completely normal. So this is a person with LTBI, but what is his best option for LTBI treatment going to be? So your options are 3-HP, that's the 12 weeks of INH, isoniazid and rifapentine weekly, 9 months of daily INH, or 4 months of daily rifampin, the 4R. All right, let's see what type of answers we got. All right, so we've got a little split here, and we're going to discuss what we think about this. So next slide. So this is an answer that I would choose. I know a bunch of you chose 3-HP, and maybe I've actually blindsided you into choosing 3-HP for everything. That's not a bad route to start pushing you down, but there's a couple of issues here. Now, remember I said INH, no matter how we use it, whether it's in the 3-HP formulation or the 9 months, is our most hepatotoxic drug. Now, rifampin can also elevate your transaminases, but INH is the one that's most notorious for that. And I guess the key things in here are that this person has had multiple admissions for cirrhosis and hepatitis and is starting out with his baseline liver functions elevated. In this case, I would like to choose what is potentially the least hepatotoxic option for him, okay? So that's why I would lean towards the 4 months of rifampin in this patient, okay? I would definitely put the INH as my last option, the 9 months. All right, well, let's wrap this up. So in summary, in the United States, the identification and treatment of LTBI is a cornerstone of TB elimination and management. LTBI treatment regimens should be based on drug susceptibility results of the presumed source case. We didn't talk too much about if you got your LTBI from a drug-resistant patient. That is a completely different discussion if it's somebody who is exposed to an MDR patient. But we also consider your coexisting medical conditions and the potential for drug-drug interactions. And finally, short-course rifamycin-based treatment regimens, 3-HP or 4R, are highly effective and are preferred for reasons of convenience and higher rates of completion. Next slide. So let's go back to that text that I got. And now we're going to see if we can read it through. I'll try to put it all into actual words and see if this makes sense to you now. So what we had and what I was being texted about was a 44-year-old female with diabetes who was HIV positive and on antiretroviral therapy. The tuberculin skin test was negative, but the quantiferon test was positive. The chest x-ray showed no active disease. Was this TB disease or LTBI, latent tuberculosis infection? The liver function tests are within normal limits. If it's LTBI, do we use 3-HP or do we go with 4 months of rifampin or 9 months of INH? If we use 3-HP, do we use rifapentin or do I need to substitute in something else? And in this case, I didn't go over this. There's another medicine called rifabutin, but that is not part of a 3HP protocol. And then the last question was, if I need to do direct observed therapy, is video direct observed therapy an okay option? Thanks. All right, next slide. So here's how we responded back, and I put it all in spelled out things here. And what I said is, if your HIV positive patient has a confirmed positive quantiferon test, a normal chest x-ray, and is asymptomatic, this is likely LTBI. With normal liver functions, she may be eligible for the self-administered 12-week course of rifampicin and isoniazid, but only if you first check for drug interactions with her HIV medications. Please call me for any questions. Next slide. And that's my closing thought, and Sherry highlighted that very well. Call when you have questions. TB is a disease that's being done less and less and less in the United States. And there is not as much experience out there as there used to be. So never hesitate to pick up the phone and call somebody who might know a little bit more than you do to help you walk you through settings. Thank you very much. And I'd be glad to try to entertain any questions here.
Thank you so much, Dr. Yost. Alyssa has been keeping track of the questions in the chat, so she's just going to go ahead and pull those up on a Word document. And all three of you, Evan, Sherry, and Dr. Yost, if you want to just kind of go through these questions and share your responses, I think that would be the best way to approach this. And as new questions come in, we'll add those.
All right, first one, for 3HP therapy, do all 12 doses have to be taken if only 1 or 2 weeks are missed? There we go. Does the therapy still only last for 12 weeks total? No, if you miss a week, you add on another week. So if you missed week 4, then you just add that week on to the end. And again, you have 16 total weeks to get the 12 total doses in, okay? Another question, did he have a COVID vaccine? Can cause a false positive? I am not aware of COVID vaccines interfering with that. And as Sherry was mentioning, we do not advise spacing with testing.
Yeah.
Sherry, if you have any more information on that.
My understanding is that the issue was that there was like some concern about it causing a false negative, not a false positive. And that's come for administrative purposes. They weren't sure about how to space them, but there's been no evidence of that at all. And it is not a live vaccine, so there's no reason to space them whatsoever. There's no evidence of the two interacting.
Yep. Okay. What is your recommendation for somebody on 3 times weekly dialysis who has a positive IGRA and negative chest X-ray, asymptomatic? Yeah, so this is a tricky one with LTBI patients who are on hemodialysis because most of the medications can be dialyzed. We have used 3HP. We tend to try to pick, almost everybody who's on dialysis has some point in their weekly schedule where there's a 3-day gap. If you're a Monday, Wednesday, Friday, then your gap is the Friday to the Monday. And we have you get dosed immediately after your dialysis. I will tell you, to be honest, I usually sit down with the nephrologist and oftentimes with one of the clinical pharmacists because it can also impact, depending on what other medications they're on, how long their dialysis run is, some of the other factors that go into dialysis. But I can say that on occasions we have used 3HP, selecting that longest interval possible. When would you want a full year of treatment? I would say very, very rarely. Treating LTBI for more than 9 months is something we just really don't see much of anymore. When we were using primarily 6 and 9 month INH monotherapy regimens and people interrupted and dropped out for a month, we found ourselves restarting and extending, and sometimes people were on treatment for up to a year, but that was pretty uncommon. In a patient with LTBI who has completed LTBI treatment, what is their risk to develop TB disease in their lifetime despite their LTBI treatment? It's a good question, and it is not zero. Let's put it that way. Sometimes it does depend on whether they develop other significant immunosuppressive conditions later on. I think anybody who has done TB long enough has seen a reactivation of a treated patient. I just dealt with an 80-year-old female who was a cancer patient who years and years ago in the 1960s was treated with INH, well documented, and she reactivated. For that reason, it needs to be on people's problem lists. We need to tell people that this was the best treatment that we had, and we believe it has reduced you to a very, very small risk, but particularly if you develop immunosuppressive conditions, your future provider should know you were treated for LTBI. Do we know about COVID and TB interactions? C19 activated LPI or other infections facilitating each other? That is still in evolution, I would say. We have known for years that diseases which damage people's lungs can result in what appears to be a higher incidence of TB and certainly complicated TB. Our suspicion is that that may prove to be the case with COVID, but no, I don't believe we have any firm answers on that. Please review.
Evan can also add something to that as well from the state epi side about the interaction.
Mm-hmm.
Yeah, so as a process, we do periodic matching through the surveillance records. And so generally across Arizona, we have about 28% of individuals with a suspected reported positive COVID result. What we're seeing across our TB patients for both 2020 and 2021 case years is right around that same amount or proportion of positivity in an identified match. There was no difference that we saw, at least at that point in time, in reporting about treatment outcome changes. So that means like completion of treatment or dying. We didn't really see any differences with the site of diseases between individuals who were TB COVID versus just TB only. We did notice that there was a slight uptick in miliary notation on chest imaging for individuals with TB and COVID compared to TB only, but I think we'll need more information before we can really point at something.
Okay. Next, please review when to use 6H or 9H. Oftentimes the reasons we will go to a isoniazid monotherapy situation is a person who has a really high potential for drug interactions using a rifampin or rifapentine based protocol. An example we had is a lady who had a prosthetic valve whose anticoagulation for her valve was so tenuous that every attempt to use rifampin just threw her INR way off. We ended up deciding to go to an isoniazid monotherapy type of thing. So I think drug interactions are one of the issues. There are certain people who can't tolerate either a rifampin or isoniazid alone. They have other side effects. We didn't talk too much about it, but even the 3HP regimen can induce some flu-like side effects with people. And we've had to make that decision to drop one or the other drug and go to either straight rifampin or straight isoniazid. T-spot is less expensive than quantiferon. Is it just as good? In generally, we view them both as being equal forms of IGRA testing, but you do say you've had a lot of false positives. So as I mentioned, there's no gold standards. You do have to be prepared for false positives and false negatives. One of the beauties about TB is there's a lot of art to TB, and there's points at which the science, you wished it was stronger, but you have to make some decisions. And so sometimes we have to really just look at the results of an IGRA in view of what the person's risks were. You know, what were their exposure risks? Where did they come from? What are their future risks? What are the chances that they're going to have some immunosuppressive issues or do have some immunosuppressive issues around that? But you will have false positives both ways. And those numbers have been reported anywhere, I believe, from 5 to 15%, depending on the population. So, but I know in Pima County, we use exclusively T-spots. And part of that is a contracting reason. But I think they can be used reliably, but look at the big picture of the patient.
We've got about 2 more minutes for questions. We do have to wrap up in 3 minutes, and we have one more slide on the CME. So just about 2 more minutes to finish up these questions. Thank you.
Sure. I think
I have a quick thing to add to that. And I think part of the issue is because we're testing low risk individuals for administrative purposes. And this is something that comes up with the screening of healthcare workers who are no longer at risk. And you do the risk questionnaire and they have no risk of being exposed to TB because it's such a low risk of having TB now in the United States that being a healthcare worker does not usually put you at risk. Right. Usually it's other things. And so I believe that CDC has recommendations to that if you have a low risk healthcare worker who tests positive, you repeat a test. And then if that is negative, you believe the negative. And it just has to do with stats. It's the positive predictive value basically becomes extremely poor when you're testing people that did not have TB infection. Now it's different if you have HIV patients. So I don't know if you wanted to add anything to that, Dr. Yost.
Yeah, I think that's well said. And I'll touch very briefly on the last 2 questions. Should individuals with a BCG scar get tested for TB? Yes, BCG, we could talk days on that, is not a preventive vaccine in the same way we think of measles or even COVID or something like that. We know that the IGRAs, the blood tests, are generally not interfered with by prior BCG vaccination and can be a reliable way to test those people who have had it. And lastly, if you were exposed to MDR TB, what are you going to do? You're going to call an expert because the answer is there's regimens that are out there. They're often based with fluoroquinolones, but they're complicated. And that's where you need to be reaching out. And TB involves a lot of hand-holding. And this is one of the classic cases where you need to reach for advice.
Thank you so much. Alyssa, if you don't mind stopping the screen share, and then Jeannie, if you want to pull up our final slide of the day. We just want to wrap up with some reminders on the CME. But as you do that, I want to say thank you to Dr. Yost. That was an excellent way to end the day. Thank you for your case studies, and thank you everyone for your questions. So Jeannie, if you want to take it from here, it's all yours.
Sure. I have like 3 slides for continuing education units. Today's training is 4 units, no partial credit will be awarded. And successful completion includes pre-registration, staying for the entire webinar. And number 3 here is the completion of the evaluation and the Qualtrics survey. And the Qualtrics survey looks like this. So after you complete the evaluation, the Qualtrics survey will automatically be directed for if you're asking for continuing education units. And for CME questions, please contact us at Curry TB Center at UCSF. And certificates will be available on the Curry website, approximately maybe 12 weeks, but sometimes we'll do it a little bit earlier. And when the certificates are available, we will send emails with instructions on how to access the certificates. Thank you.
Thank you so much, Jeannie, and thank you to everyone who made today happen. You will get the evaluation link as soon as you close out of the Zoom, and we will be following up via email with that link and the many, many other links that were shared today to additional resources. If you have any additional questions, or if you would like access to resources, or if you want to be connected to any of our speakers, please let us know. I think we can all agree, and everyone has said it multiple times today, we'd love to hear from you. So thank you all again. And with that, you're free to exit the Zoom and let us know if you have any questions.